All right, I have 11. So welcome back to day 2 of the clinically meaningful outcomes in AD and ADRD trials workshop. I'm Luke Stokel from the National Institute on Aging, and I welcome you on behalf of the NIA and NINDS Planning Committee. Yesterday, we began our conversation about what matters to people living with dementia. We heard about needs for equity in cognitive measurement, including more representative samples in our trials. We also heard about exciting new advances in digital tools and techniques for measuring meaningful cognitive change in trials. Finally, we discussed the impact of these diseases and therapies on everyday function, including priorities for research participants living with these diseases across disease stages. This included a reminder that research participants own their data, have the right to receive individual results or not, to exercise this right in an informed manner, have research results explained in easy to understand terms and with sensitivity, compassion, and patience, receive follow-up to check on well-being after receiving results, and decide on what actions to take after receiving research results. Today, we'll hear about clinical meaningfulness in the community, including expectations of Alzheimer's disease and Alzheimer's disease-related dementia interventions, and how to measure clinical and biomarker change over time in the general population. We'll hear the refrain, "Get out of the ivory tower and amyloid box," for development of blood-based biomarkers to capture pathologies that contribute to clinical decline in diverse populations. We'll also hear about needs for development of a patient and care partner reported outcome that could become a standard clinical measure, and we'll discuss development of measures and models that quantify the short and long-term meaningful health and financial benefits of treatments, which could be used by various stakeholders. As a reminder, please use chat for questions. We'll break at 12:50 p.m. Eastern Time, and we'll close at 2:45 p.m. Eastern Time. Up first, Dr. Ron Peterson, the Cora Canal Professor of Alzheimer's Disease Research at the Mayo Clinic College of Medicine in Rochester, Minnesota, to discuss clinical meaningfulness in the community. Ron?
Thanks very much, Luke. I appreciate the opportunity to participate in this meeting. I want to thank NIA, NINDS for putting this meeting together. It's critically important in our field at this point in time. So I want to thank you, Luke, Nicole, for doing the heavy lifting, bringing us all together, and to Jennifer, who's going to advance my slides, which is going to mean she's going to have to stay awake during this, which is challenging for her, but I appreciate it. So you've mentioned, Luke, that we want to move some of these measures of clinical meaningfulness into the community. That is, we've been focusing on the clinical trials, and I will focus on clinical trials in Alzheimer's disease in particular. Yesterday, we're not only talking about Alzheimer's disease, FTD, DLB, VCID, and across the clinical spectrum. But really, the measures we're using are very important, insightful into how these diseases are progressing and how the interventions are working. But how do these measures perform in the general community? So we've been asked actually by regulatory authorities in this country and in Europe to say, gee, you guys have longitudinal data on an aging population in the community on many of these measures. So can you bring these into perspective with regard to clinical trials, how these measurements move? And so that's sort of my focus for today. Next slide, please. My disclosures here are largely, we're funded by the National Institute on Aging for most of our work. I do some work with the companies, but because I'm involved with the Alzheimer's Clinical Trials Consortium there on the right, as one of the co-PIs, this precludes me from taking more than $1.50 from any of the companies on the left. So in fact, I stay involved with what's happening in clinical trials, but it's not significantly impacting anything else I'm doing. Next slide, please. So over the years, we've sort of focused on clinical trials and what's happening when we intervene with a particular aspect of the disease process. But we've also come to appreciate in recent years that cognitive impairment in aging is not just unifocal. That is, while we focus on Alzheimer's disease, actually, when you see a person in his or her 70s or 80s who's becoming cognitively impaired, what is the cause? Well, might be Alzheimer's disease, might be amyloid, might be tau, but odds are there's an element of alpha-synuclein producing Lewy bodies. There may be an element of TDP-43 contributing to late disease. There certainly is going to be some degree of vascular cognitive impairment. There may be CSF dynamics that are involved. So if in fact we have this complex picture and people are becoming cognitively impaired over time, and we intervene on one element, say amyloid, albeit successfully, meaning that we actually lower the amyloid levels in the brain, what is the likelihood that we're going to see that clinically in the performance of the individual patient? And that's why we put out this paper in the next slide that looks at the expectations of what we might see from these clinical trials if we intervene in one element. And the next slide, you'll see the hypothetical model that we put together looking at, okay, if we look at the blue dotted line here as being the placebo curve of cognitive impairment over time, the red dotted line refers to, okay, we intervene at a certain point, and now we're actually modifying the course of progression. How might we depict that in a meaningful fashion? The yellow box there is meant to characterize the fact that these are 18-month trials often. So in that relatively short period of time, and we're intervening on a process that has likely been accumulating over years, maybe decades, what might be a reasonable expectation? So the vertical arrows there depict the difference between the placebo group and the intervention at one point in time. 18-month trial, yellow box. Presumably, these are going to expand over time, although this is very hypothetical. We don't know if intervention on that particular element is going to persist over time, persist at the same degree. Is it going to be linear? All of these are unknowns. But presumably, if we're altering an underlying disease process with a disease-modifying intervention, we're going to we're going to result in an increased impact of the disease process over time. Then the next slide, we're talking about the time savings notion. And Suzanne Hendricks yesterday presented a very elegant description of what this means. And this means that if we're able at 18 months to alter a clinical outcome measure like the CDR sum of the boxes by 0.5 at 18 months, we're assuming then that if we go backwards on that curve horizontally, where would that person on the placebo curve have been? And that might result in a rough approximation of a time savings measure. Could be 4.5 months, 6 months, 8 months over time. So when we present the impact of these drugs, disease-modifying drugs to patients, we say, oh, this drug produces a 27% slowing of the rate of progression on the CDR sum of the boxes. Patients have no clue what you're talking about, nor should they. So the way we tend to present this is saying that, well, if in fact you're functioning at this particular level at this point in time, and we intervene with this drug and it's successful, we're hoping to keep you at your current level of functioning or close to it for another 4, 6, 8, or 9 months. And then we present that in the context of, here's what it takes to receive this drug, here are the potential side effects, and we enter into a discussion with the patient as to whether they want to weigh this plus versus minus with regard to the treatment. And then we have the discussion and the patient makes a decision, yes, I'd like to pursue this. So the time-saving element has been very useful in trying to characterize this to patients in a meaningful fashion. Next slide, please. So I mentioned the CDR as one of the primary outcome measures of many of the trials. This is the clinical dementia rating. It was developed in the late 1970s, maybe early 80s by Dr. Leonard Berg at Washington University in St. Louis to try to characterize how clinicians deal with patients in taking a history. So Dr. Berg and his colleagues sort of developed this structured interview, which characterizes how the person is doing from somebody who knows the patient well, and try to put all this information together in a subjective judgment scale, going from 0 to 3. So 0, 0.5, 1, 2, 3 as the global CDR. But there are 6 domains that go into the CDR as outlined on this slide, and each domain can be graded as 0, 0.5, 1, 2, 3. So this has been a useful scale, but it's important to realize that this is a severity rating scale, not a diagnostic instrument. And I'm not a statistician, believe me, but if I remember correctly from our statistics work, that there are various types of scales of measurement: nominal, ordinal, interval, and ratio. And I think this scale is probably at the ordinal level, meaning that a 1 is less than a 2 is less than a 3, but that does not necessarily imply that the distance between 1 and 2 and 3 are equivalent. So in the next slide, I've broken out a couple of the domains that are actually involved, looking at these more carefully. So one of the criticisms of the clinical trials that have been done with Alzheimer's disease modifying therapies is that, yes, biologically, they reduce the amount of amyloid in the brain. We can see it on PET scan. But does that have a clinically meaningful impact on the patient? And so what we've been seeing are, so after 18 months, about a 0.5 change in the CDR sum of the boxes. Well, this is an 18-point scale. Come on, how much is a 0.5? Does 0.5 really mean a difference? But going back to the scale properties now, a 0.5 difference, when you're looking at a sum of the box of 1.5 versus 2, or 0.5 versus 1, is much more impactful than, say, a 0.5 change at 16.5 to 17.0 on this 18-point scale. I submit that that is imperceptible to the clinician, to the patient, to the family. But at the early stage in this scale, again, not being an equal interval scale, that this is a meaningful change at 0.5 to 1. So let's look at the memory domain. Memory domain, questionable, 0.5. Consistent, slight forgetfulness. Partial recollection, benign forgetfulness. If you go a 0.5 sum of the box to 1.0, we now have moderate memory loss, more marked for recent events. Defect interferes with everyday activities. Community affairs, 0.5, slight impairment in these activities. 1.0, unable to function independently. So if we look at clinical criteria along the spectrum, cognitively unimpaired, mild cognitive impairment, dementia, what's the difference between mild cognitive impairment and dementia? Yes, the cognitive tests get a little bit worse, but the fundamental feature is loss of independence. At mild cognitive impairment, people can function independently, less efficiently, but independently. When you get to the dementia stage, even a CDR1, the person has lost functional independence. That's a big deal. I submit that that's a clinically meaningful change for people, and consequently, a 0.5 sum of the box change in this range is in fact clinically important. Next slide, please. So how do the clinical and biomarker measures change over time in the general population? Again, going back to the question that was put to us by regulatory authorities. In the next slide, we're using the Mayo Clinic Study of Aging, which is an NIA-funded longitudinal project in Rochester, Minnesota, characterizing people in the community. And in the next slide, we can see that the individuals are randomly sampled from the population. We know who the people are who live in our area, in our community. So in fact, we can do an actual random sample of the population. We started in the next slide, we started sampling people in back in 2004. Some of them remain in the study, but we've resampled over time to keep the cohort at about 3,000 individuals. So this study's been going on for about 20 years now. In the next slide, you'll see that back in 2004, when we began the study, we sampled 70 to 89-year-olds, because that's kind of where the action was. But as biomarkers for Alzheimer's disease became available, particularly imaging biomarkers, in 2012, we went down to 50-year-olds, and with tau biomarkers in 2015, we went down to 30-year-olds. So in fact, now we're sampling 6 decades of aging randomly. And the next slide, you can see the characteristics of the current population. Almost 3,000 people, equal number of men and women across the age spectrum. We follow people into their 90s, but we oversample in the 60s, 70s, and 80s. Now, when we bring people in from the study, in the next slide, you can see that everybody gets a full evaluation. That is, we do not stratify people. If your mini mental is this, you get this. If your mini mental is that, you get that. No, we take everybody and we do a full evaluation on everybody. So, and we draw blood on everybody going back to 2004 annually. So we have all this biomarker information archived over time. In the left-hand column, we see that a nurse study coordinator takes a medical history, goes through the medical record, gets a family history, logs medications, and asks permission to speak to somebody who knows the person well, such that we get a CDR and an FAQ. In the middle column, you'll see that everybody sees a physician, has a medical examination reviewed, neurologic examination, mental status examination, and in the right-hand column, we have the thorough cognitive evaluation, 4 cognitive domains, 9 tests. Then each of those 3 inputs come together on Tuesday afternoons, and we argue every week about, is this person normal or not? What about this 82-year-old woman with COPD and diabetes that's sort of in control, not really in control, and how is she doing with regard to her cognitive function? And given that, the output then in the next slide is we categorize people in the database according to either cognitively unimpaired, normal-ish, or mild cognitive impairment-ish, or dementia. And you can tell that these overlap at the boundaries for mild cognitive impairment. But importantly, we make this determination in isolation with every visit. That is, we do not know what their diagnosis was last year when we saw them. We don't know what their cognitive tests were last year, and for sure, we don't know their biomarkers. So we do an independent clinical assessment at each visit. And I think that gives us a sort of a objective view of how people are doing at this particular point in time. So this is important because the data that I'm going to show you were generated using this scheme. And in the next slide, you'll see that what we've tried to look at are clinically meaningful transitions. That is, in our database, we're looking at people now who have transitioned from cognitively unimpaired to MCI and MCI to dementia. We think these are anchor points. I may or may not be using that term properly, but I think these are clinically meaningful anchor points. And while you can say, well, isn't that circular, Peterson? I mean, come on, you're using the data. In fact, when we make these clinical calls, we do not sit down and say, gee, what's this person's CDR sum of the boxes? What's this person's FAQ score? Rather, we take the gestalt of how the person is doing, the input from those 3 clinicians, and we come to a meaningful, hopefully meaningful, clinical judgment as to how the person is doing. So to go back again, we're taking these 2 junctions, namely the transition from unimpaired to MCI and MCI to dementia, as clinically meaningful points. Next slide. So with that as a backdrop, then, we took our database and we looked at 3 cohorts that may inform us about how these transitions are occurring. One is cognitively unimpaired people who transition to MCI, and then a subset of those who are biomarker positive. That is, by PET scanning, they're amyloid positive, because these individuals would be more representative of what's going on in the clinical trials for Alzheimer's disease. And the third group is MCI to dementia. So Next slide. The key questions then are, how do these longitudinal measures perform? Clinical measures, various rating scales that we have, imaging biomarkers, fluid biomarkers. How are they varying on these two transition points, CU to MCI, MCI to dementia? Next slide. To put this in some perspective now, here are the results from one of the recent disease-modifying therapies. This is the Clarity trial with lecanemab. And what we're seeing here is the reduction in the amyloid PET performance in people who were treated on the bottom line. The top line then is the placebo group. We're going to focus more on the top line, that placebo group on the top. How do the people in the community perform with regard to that measure? In the next slide, we'll see the clinical impact of the disease-modifying therapy. Once again, we're going to look at the bottom line here, which is a change in the sum of boxes on the CDR, 0 being starting at the trial, 18 months later, about a 1.6 reduction in the placebo group now. Is that representative of the real world? And in the next slide, we have similar data from the Trailblazer Owls 2 study, which is the donanemab trial that is under review right now by the FDA. And in the right-hand panel here, we see the change on the CDR sum of the boxes in this trial, which goes down to maybe 1.7, 1.75 change in the placebo group. So this seems to be an important change over this point in time. And in the next slide, we have a few of the other biomarkers that are followed in this trial. Amyloid plaqueoid load on the left, plasma p-tau 217 in the middle, and GFAP on the right as an index of neurodegeneration. So we have most of these measures in the Mayo Clinic Study of Aging, and we thought we would take a look at how they perform. So next slide shows us again where we're going. 3 cohorts, cognitively unimpaired to MCI, that subset who are amyloid positive, and then MCI to dementia. The next slide shows, to put this in perspective again, a very important paper was published by Scott Andrews and Brandy Matthews a few years ago, outlining minimally clinically important differences. They went to the NAC database. So this is the Alzheimer's Disease Research Center program where all the data are acquired and collated. And they looked at how these measures perform with regard to one anchoring measure. That is, those of us who do this kind of clinical assessment of people who come back basically every year for the ADRC program. There's a checkbox in your assessment of the people. Have they changed in a meaningful fashion from their last visit? And you check the box, yes or no. Using that then as an anchor point, Scott Andrews and Brandy Matthews and their colleagues then said, okay, around that change point, what is the CDR sum of the boxes change? Came up with the measure of 1 to 2 points. The MMSE changed about 1 to 3 points, and the FAQ changed 3 to 5 points. So we use this then as another anchoring point for us to interpret our data. So next slide, you'll see the cohorts that we're looking at, the 3 cohorts. This is the CU to MCI. Important point here. Notice the mean age. 83. Most of the clinical trials are talking about people in their early and mid 70s. We're looking at an older community population because that's the way these diseases play out in the general community. Roughly equal number of men and women. Education, 13, 14 years, but importantly, about a quarter of them have high school or less of an education. On the bottom there, we see the Charlson Comorbidity Index. This means, do they have other illnesses? And the answer is yes. These people have hypertension, they have diabetes, they have congestive heart failure, they have psychiatric comorbidities. We include them all because it's a population-based study. On the right-hand column, we have the CDR sum of the boxes, 1.3. This is low-ish, meaning that these people are milder when they convert to MCI. Whereas in the clinical trials, the CDR sum of the boxes was more in the range of 3.2 to 3.7. So these people are mild, and the FAQ score reflects that. And the next column, next slide, we have the subset of people, again, who are now amyloid positive, kind of the same picture as what we saw on the earlier one, maybe a little more impaired, And in the next slide, we'll see the cohort that has progressed from MCI to dementia. Now, they're a little bit older, as you would expect, 85, slightly more men than women, medical comorbidities, a few more given their age. And the CDR global score is 0.5 or 1. So most of the people in this population are mild with regard to dementia, people we have followed from MCI to dementia. And at their juncture point, when they become dementia, the diagnosis of dementia, there, some of the boxes is up to 5.2. Okay, next slide. Grab a strong cup of coffee, because now I'm going to flip through a bunch of data slides that depict what we're looking at. And these slides haven't transitioned very well because they don't, the axes are not labeled. So on the bottom, the x-axis, the middle point is 0, meaning that in this group, these are people who have gone from cognitively unimpaired to incident MCI. And the y-axis is missing there, but we have CDR, some of the boxes. So what we're seeing is a gradual transition that people are changing over time. And in the right-hand box, we have the CDR memory domain. Next slide, please. Again, here is the subset of people who are amyloid positive. And in the next slide, we can click through these. These are, again, so that bottom point that's not labeled there is the 0 point when people have transitioned from cognitively unimpaired to MCI. Next one, Jennifer. And here's what the CDR, some of the boxes, and the memory domain look at. Again, the middle of the x-axis on the bottom is the transition point from MCI to dementia. So you can see that things are starting to happen around that transition point. Next slide, we're focusing again on that point just prior. On the right-hand side there, we're seeing the transition point. Here's cognition. So here we're looking at the mini mental in the upper left, the Mayo PAC, which is a combination of the ADLT, Trails B, and a fluency measure that looks at overall global cognition. The bottom left is a global cognitive score, Z-score, and on the right is the memory score. So this is how they look in the incident MCI group. The next slide will show you what the subset of amyloid positive, same trend, a bit more exaggerated. And the next slide, we have the people transitioning to dementia. And again, we see the same kinds of patterns, but things are happening around these transition points that suggest that they are, in fact, meaningful transitions for the people. In the next slide, we have, this is the ECOG, which is a subjective cognitive impairment rating by the participant. I put informant, should put study partner here. And what we lose on the bottom, again, the middle point on the bottom is the transition point. And we see that the informant or the study partner is actually more insightful into the degree of cognitive impairment than the participant prior to the point at which they transition to MCI. And the right-hand side, we see the FAQ score. Next slide. Same information now in the amyloid positive subset. And we see here that that juncture, the crossover point is even earlier. Prior to the diagnosis of MCI, the study partner is seeing some changes in the study participant. FAQ, of course, is rising even more rapidly. And then the next one, we see that in the dementia cohort, next one, the dementia cohort now, we see that the informant is much more insightful than the participant with regard to degree of impairment that's going on, and the FAQ scores are going up rather dramatically. Next slide, please. Next one, there we are. Now we look at some behavioral measures here, and here we're looking at the Beck anxiety inventory, the Beck depression inventory, the bottom right, the NPI, the neuropsychiatric inventory. And again, these are changing a bit more gradually, but are starting to transition as well in the overall incident MCI. The next one is the same kinds of smaller groups. So the error bars are wider, but the same transitions are seen in the amyloid positive subset. And in the next one, the dementia subset. Interestingly, now things are starting to flatten out. So is this an element of anosognosia? The people are less aware or less bothered by their clinical symptoms as the disease progresses. But on the NPI, we're starting to see that, in fact, this is going up by the observer. Next one, please. Now we're looking at some of the biomarkers. So now we're looking at amyloid PET scan results. Again, the bottom point is the 0 point, and we're seeing that the amyloid is steadily increasing. At this early phase of the disease, we're not seeing very much of a tau change, a PET tau change with regard to an overall ROI, a meta ROI for tau is not changing this early stage in the disease. The next slide will show you the subset of people who are amyloid positive, a little bit more on the left, something of a change in tau on the right. And the next one, we're seeing, interestingly, that in the dementia phase, next one, please, Jennifer. There we go, that things are starting to plateau. And if you're familiar with the Jack curves, the sigmoidal curves of amyloid and tau, you will note that, in fact, there is a stage where they start to plateau, and that may be what we're seeing there. Thank you. Next one, please. Plasma biomarkers, A beta 42 to 40 ratio that would be declining over time in the incident MCI group very early, but the amyloid probability score, which combines not only the A beta 42 to 40 ratio, but the p-tau 217 phosphorylated to non-phosphorylated ratio, is starting to pick up a change at this very early stage. And in the next slide, we see the same picture in people who are amyloid positive. And then again, interestingly, in the next slide, we see in the dementia phase, these become less insightful as to the process. So some of these fluid biomarkers may be most informative early in the disease. Next slide, please. And then with regard to measures of neurodegeneration, NFL over time, GFAP, next slide, providing some information. And the next slide, we'll see the dementia range. And again, these are changing and provide some more information with regard to the underlying pathophysiology that is rolling out. Next slide. Okay, going back then to the Andrews paper, looking at the CDR sum of the boxes, 1 to 2 points, mini mental, 1 to 3 points, FAQ, 3 to 5. In the next slide, then, we show the actual data with regard to these numbers in the MCI group. And in the next slide, Jennifer, there we go. It's kind of hard to read here, but the yellow indicates that, in fact, the CDR sum of the boxes at the incident MCI point is changing about a half a point. MMSE is changing. The central FAQ, PIB centiloids are changing at that period of time. The next slide. These are the amyloid positive subset. And again, we see in the next slide, the CDR sum of the boxes now is changing a greater amount. The mini mental is a greater FAQ. And all of these measures in the amyloid positive group are changing at this early juncture point of normal to MCI. In the next slide, then we see how these change in the dementia range. So in the next one, which shows the actual changes now of the CDR sum of the boxes, 2.2 to 5. So now we're seeing a significant change. Mini mental is changing, FAQ is changing, and the centiloids are going up rather dramatically. So point being, the next slide will, I think, bring all this. I apologize for this. In the general population, what we're saying here is that there are two clinically meaningful transition points, the CU to MCI, the MCI to dementia. And it appears that what we're seeing in the general population around these points of transition, that the CDR sum of the boxes change is about right. The cognitive scores corroborate what we're seeing with the overall global CDR. The biomarkers are consistent, and the behavioral changes are somewhat less dramatic. That could be a measurement issue as much as it could be a reality issue. But I think what we're trying to demonstrate here, as we've been asked, do the measures that are being used in the clinical trials, do they reflect what's going on in the actual population? And in the last slide, I'd like to thank all my colleagues in the the study of aging who really contributed to all this, particularly the two folks on the right there, Jeremiah and Maria, who put all of these data together specifically for these meetings. So let me flip it over to you, Chris, to take it from here. But again, I appreciate the opportunity to share these data.
Thanks so much, Dr. Peterson. Thank you. Hi, everybody. Chris Weber, Director of Global Science Initiatives with the Alzheimer's Association. And I'm going to jump right, as your moderator for session 3, I'm going to jump right into my moderator responsibilities now for session 3. And maybe we just want to, I think we have time for a question. Ron, do you want to just stay on camera just for this one question here from, it came through the chat from Joe. Maybe we can do this one question before we start off with session 3. I'll read it here. It says, does Mayo try to assess the probable contributions of comorbidities on patients' cognitive decline? For example, 70% of this may be vascular disease as seen on MRI, but they do have AD as well.
Yes, good question, Joe. Thanks for asking that. Yes, because we have the medical histories on all these people, because there are patients, we do have their medical comorbidities, how they measure, how they pertain to contribute to the cognitive impairment. We also have other biomarkers. We have cerebrovascular biomarkers. We do a lot of MR. So we actually put together a multifactorial model of cognitive decline as a function of AD biomarkers plus vascular biomarkers plus their medical comorbidities. So we do that.
Excellent, thank you. All right, I think we're, how are we doing on time? How are we doing on time? Should we go right to starting with session 3 and maybe hold these questions for our general discussion after?
Yeah, that sounds good.
Sound good? Okay, thanks, Luke. All right, thank you, Dr. Peterson. Wonderful talk here to get us started on this keynote. Thank you. It's overall, this has been just a great workshop, great day 1, great presentations on our theme of clinical meaningfulness. And thank you very much to our NIA, NINDS colleagues for hosting this event and inviting me to participate in this really fantastic opportunity to bring together a multidisciplinary group for these discussions. And this session now that you see on the slide here on the biological markers to assess whether an intervention has had a clinically meaningful impact is extremely relevant to this conversation. And of course, now we have approval of disease-modifying treatments for AD that have really changed the evolving landscape of AD research, and we're reckoning with the importance of measuring the rate of underlying disease progression and defining what represents a meaningful change or slowing of clinical decline for patients. And this audience on the call today, you're very familiar with the challenges, especially in research, of demonstrating clinical meaningfulness at the individual, at the patient level, especially in early stages of the disease. And some of the points made by Ron now and just now and yesterday too, really underscore the importance of early diagnosis, the frustrations of misdiagnosis, and overall being able to provide more time in the early stages of the disease. And that's what's meaningful, when you have your memories and functioning intact. And one of the efforts led by the Alzheimer's Association I want to mention, because I think it has a lot of relevance to this session and the importance of early and accurate diagnosis, is the revised criteria for diagnosis and staging of Alzheimer's disease. Thanks, Amber. A draft of the criteria, I just wanted to mention this briefly here and say that a draft of the criteria has been available online since about mid-2003, and I'm happy to drop that link in the chat too, where you can look at where that's housed. And after public commentary and some revisions, it's currently in review, and we look forward to its publication in the near future. And I think at the heart of these criteria, they underscore the value of current and emerging biomarkers, really for a more accurate diagnosis of AD based on what we know about the biology of the disease. And I think a prime example of this is the incorporation of emerging blood tests into these diagnostic criteria. And these revised criteria, I think, really represent a a treatment and diagnostic process that are used in other diseases too, cancer, heart disease, diabetes, where early and accurate detection is essential to disease progression. I mean, you wouldn't wait to treat colon cancer until it metastasizes. You get screened for cholesterol and treated rather than waiting for an MI from vascular disease. So this isn't unique to Alzheimer's. So I think this is moving the field in the right direction. Before we kick things off here with our speakers, wanted to, as we have done in the format of our previous sessions from yesterday, I just wanted to review the gains and opportunities here, gaps and opportunities. I guess when we were organizing the session, we thought that there were three main takeaways that we wanted to sort of put out there. Advancing Alzheimer's, advancements of Alzheimer's disease biomarkers must include diverse communities. I mean, this first one, we have to embrace diversity in our research efforts and ensure diagnostic and therapeutic developments are applicable and equitable across populations. And the best time to think about this and to have these discussions about this strategy is in the study design phase, not after enrollment has started. Our second point emphasizes the importance of refining measurement approaches in Alzheimer's disease. And our third point about expanding the toolkit of biomarkers to capture the multitude of pathologies to contributing to clinical design and decline in diverse populations. I think our biomarkers that are being developed and are really made huge advancements in the field have shown us how powerful I think blood tests can be now. They're cheaper, they're less invasive, and a lot more accessible. And they do an excellent job of capturing amyloid and brain degeneration. And we need additional biomarkers to build on our understanding of the diverse biology of Alzheimer's disease and the influence of comorbidities in diverse populations. So those are some of our GNOs that we wanted to share. And I think now we're kind of ready to, let's kick the session off here. So I'd like to introduce Dr. Sid O'Brien, who's going to be our first presenter of this session on considerations for clinically meaningful outcomes among diverse populations. Dr. O'Brien is a professor at University of North Texas at the Health Science Center in Fort Worth. He's also, I've had a chance to work with Dr. O'Brien as he is the co-chair of New Ideas led by the Alzheimer's Association, and just really happy, Dr. O'Brien, that you're here to participate in this session with all your collaborative experience in dementia science and developing tools that we need for researchers and clinicians. Feel free to drop your questions in the chat for Dr. O'Brien. And with that, Sid, I'm going to turn it over to you.
Thanks, Chris. Thank you to the organizers, NIA, Luke, huge thank you to you helping me refine my slides and et cetera. Ron, always great talk. I am going to discuss some of recent findings and opportunities for where I think we can go and where we need to go in order to make our research more applicable to the full general population. Next slide, please. And so many of you have seen this, and what we know from the research is that Alzheimer's and Alzheimer's-related dementias are experienced differently among communities of color, and such that African Americans have twice the risk and Hispanics 1.5 times the risk. Additionally, the greatest increase in AD and ADRDs by 2060 will be experienced within the Hispanic community. On top of the differential burden, there are other disparities experienced among underserved communities, such that diverse communities experience longer delays in diagnosis, oftentimes are diagnosed with more severe pathology, as well as more comorbid pathologies, more likely to be diagnosed with affective and psychiatric conditions, which oftentimes are due to cultural issues with regards to appropriateness of discussing memory loss. Also, individuals from underserved communities oftentimes live longer with the disease and then incur greater healthcare costs. So the situation is unfortunate, and we can do something about it. to date, so the ATN framework, which was presented by Ron and now will be updated again as discussed by Chris, represents a huge advancement in the field to provide a true biological conceptualization of Alzheimer's disease. Yet, approximately 90% of individuals enrolled in the research that generated the framework were non-Hispanic white. And around 90 to 95% of those enrolled in clinical trials have been non-Hispanic white. So currently, what we do not know is how does the ATN framework apply to diverse communities? And so that's been what we've been focused on and what the Health and Aging Brain Study, Health Disparities, HABS HD, is focused on. Next slide, please. And so I'm going to discuss some recent findings. HABS HD currently has around 4,000 community dwelling individuals enrolled. We have 65% from diverse underserved communities, Hispanic and African American. MRI scans on almost everyone, pushing 4,000 amyloid PET scans and pushing 3,000 PET tau scans with the associated blood biomarkers cognitive, but it's all conducted within a sociocultural and health disparities framework. So we believe in examining the biomarkers within the context of the sociocultural components. In the absence, I don't believe we can study biomarkers in the absence of sociocultural, and I don't think we can study sociocultural in the absence of the biomarkers. It leads to incomplete pictures. And so next slide, please. Let me get into some recent findings. And so as was pointed out in the chat, there was a question about ApoE4. So ApoE4, as you all know, the single strongest genetic risk factor for late onset Alzheimer's disease. However, back in the 90s, there was a publication looking at ApoE4 prevalence rates across the globe. And what's been known for a very long time is that ApoE4 rates vary very significantly and drastically across communities. And so Mohammed, a student in our group, recently published this article where they took the several of the top Alzheimer's SNPs that you can pull from dbGaP just to determine whether or not the frequency of the risk allele varied between Hispanic and non-Hispanic whites. And basically 9 of the top 11 all vary between groups. And so ApoE4 we have published previously is less prevalent among Hispanics. Others have found similar sorts of differences across groups. And we've also now shown that even the link between ApoE4 and, for example, cognitive outcome seems to potentially vary between groups. Next slide, please. What about amyloid? Well, New Ideas published a study a while back showing that amyloid positivity rates were lower among diverse populations. And we have also found the same thing across different studies. And so in HABS HD, amyloid positivity, yes, no, appears to be lower among Hispanics and African Americans. And the primary care study we ran, that one just hasn't been published yet, but that is a study for blood biomarkers in primary care. We also found that the amyloid positivity rates vary, and the A4 data has already been published and shown the same thing. So ApoE4 varies and amyloid positivity varies across diverse communities. Next slide, please. So what about neurodegeneration? So back in 2013, we published that cognitive impairment at the early stages, at MCI stage, was occurring 7 to 10 years younger among Hispanics as compared to non-Hispanic whites. And so we found then the ApoE4 rates vary. And so we were trying to understand why. And this could be due to test bias issues. It could be due to a variety of things. What we wanted to know is is there a biological something going on in the brain? And in fact, what we found is that neurodegeneration, as defined as meta-ROI positivity, is also occurring significantly younger among Hispanics as compared to non-Hispanic whites. This is likely due to medical comorbidities. Next slide, please. Now, the question also about vascular came up. And so this is a junior faculty member, Dr. Karen Meeker's work. And if you look on the bars on the right versus left, what you have is vascular positive versus negative, as just defined by white matter burden. what you see is just in general, vascular burden is higher among Hispanics and Blacks as compared to non-Hispanic whites. Once you get into the cognitively impaired groups, it becomes even more profound. And so that this mixed pathology in that MCI and dementia phase is definitely more of a rule than the exception when working among diverse communities. However, almost 30% of those non-Hispanic whites also had vascular pathology. Next slide, please. This is recent work that hasn't been yet published, but I thought it would be interesting to show because this is a structural equation model that created an amyloid tau neurodegeneration latent constructs based on imaging. So these are PET amyloid, PET tau, and MRI. And what we wanted to look at was the impact on cognition. And what we found from this work, and we've shown this in a variety of different ways, is that the link between amyloid tau and neurodegeneration, even amongst themselves, so amyloid linking to tau, supposedly, well, it is a normal is that amyloid and tau are very highly correlated. Well, among Hispanics, it's not highly correlated. The notion of amyloid then tau then neurodegeneration, our research is saying that only holds among non-Hispanic whites. And so in here, what you see, if you look interestingly enough at the bottom, the total variance accounted for in the adjusted model with all things included, it's nearly 50% of the variance of cognitive functioning is accounted for in this model. That's amyloid tau neurodegeneration plus measures of socioeconomic status, age, gender, and ApoE4. ApoE4 barely contributes to the model. However, what you see if you look at just the biomarkers, it's less than 20% of the variance accounted for among Hispanics and approximately 30% of the variance among Blacks, whereas 43% of the variance among non-Hispanic whites. So what we're seeing is that these biomarkers are very much more strongly associated with cognitive outcomes among whites as compared to Hispanic and Black participants. Interestingly enough, not surprisingly, when you look at socioeconomic and SES variables, the amount of variance accounted for in cognition is very large among Hispanics and Blacks as compared to non-Hispanic whites. More than likely, a lot of this is due to the fact that it's a bigger, what we're seeing is more people in underserved communities, lower socioeconomic status. So you have actually many studies when you're enrolling only well-educated white people, there is no variance in SES. However, what you see here is that these links vary pretty significantly. Next slide, please. And so what I wanted to do is then summarize from our data and that from others in work looking across diverse communities, what are some things that we need to do? So what about, so I'm starting with recruitment. So first and foremost, we will not in advance a precision medicine model for targeting, preventing, treating Alzheimer's in the lack of representation of our studies. It's just never going to advance. We have to get more individuals from diverse communities enrolled, not only in clinical trials, but in the clinical research, because the clinical research is informing the trials. And in my opinion, we have to get out of our ivory towers. Community engaged research is of tremendous importance because there is literature out there showing that individuals from underserved communities do not present to dementia clinics. They don't present to any specialty clinics. They're seen by their primary care providers. What we've done here, and others are doing as well, is we take the research to the community, meet the community where they are. And in that line, it's recruiting from a dementia specialty clinic. It answers certain questions. It's going to answer what dementia looks like within people presenting with memory complaints and with a dementia component. What Ron presented on the Mayo Clinic study is ideal. So what you see is in the community. And among non-Hispanic whites, the Mayo Clinic study of aging has shown has led to tremendous advancements in the field. That is where we need to do more. We need to spend more time in the community recruiting. Then there's also, I think we need to be better at holding ourselves accountable for recruitment goals. I say it all the time, stop hiding behind percentages. I'm not a fan of someone saying we're going to recruit 12% of our cohort from this or that community, because current demographics do not represent where the community is going, nor does recruitment of 10% of some population make up for 30 years of exclusion in research. And so I believe that we really need to state our numbers. How many individuals are you planning to recruit? And I believe, since we know that 50% of the United States population will be non-white, then I think 50% of those enrolled in our Alzheimer's research need to be non-white. We need to represent our community. Additionally, with recruitment, there's been changes in how people are approaching, and so more people doing community engaged approach, which is absolutely outstanding. One of the things that's happened lately is a mixture. So some folks are recruiting non-Hispanic whites from clinics, and then they're increasing representation by community engaged. The problem is now there's a confounding cohort effect of you can't disentangle recruitment methods with race and ethnicity. And so we need to even recruit our non-Hispanic whites from the community. If we're going to do a clinic-based study, then we need to recruit the diverse populations from the clinics. We're going to have real issues interpreting data that does not do that. Next slide, please. What about measures? There's a huge opportunity with existing data and existing measures that is not being taken advantage of, in my opinion. We can use item response theory and structural equation modeling to look at existing measures and even build ways of determining with existing measures, how can we optimize examining, scoring, and using the measures within different populations. And all it takes is item level data to do that. And people like Paul Crane have been doing this for many years and can lead that effort. And the same thing with structural equation modeling. I think the IRT and SEM models offer tremendous advances. Then there could be obviously needs for new measures. I believe that we need to have new measures, but I think we also need to be informed on what those new measures are. When you're working with multi-ethnic, diverse communities, one has to ensure that this scale is somehow comparable to this scale if I need one scale for one community, another scale for another community. So we need to be very careful with those things. Next slide, please. Biomarkers. And so the advancement of ATN, the advancements of these imaging plasma CSF biomarkers have absolutely revolutionized the field. What was previously unknown, however, is the fact that the imaging biomarkers, prevalence and presence vary by race and ethnicity and by across their groups. The link between those biomarkers and meaningful clinical cognitive outcomes also varies by groups. The medical comorbidities that are more prevalent among underserved communities are also differentially related to those imaging outcomes. And so in our recent data that's not yet published, even the sequence of the biomarkers varies. So it's not amyloid tau neurodegeneration, it varies by groups. Plasma biomarkers offer tremendous advantages to the field. In my opinion, they don't replace PET or CSF, nor in other fields of study is that the use. Plasma markers are absolutely amazing, and they can tell you who needs and who does not need confirmatory diagnostics. However, the medical comorbidities that vary between groups also impact the prevalence of those biomarkers, and Michelle Mielke has shown that, as have we. The link between the plasma markers and the outcomes also varies. The link between the plasma markers and the imaging outcomes varies. One of the things that I think is of tremendous opportunity here is that by understanding the sociocultural factors, understanding the impact of these medical comorbidities and the differential link to these comorbidities and these biomarkers and clinical outcomes, that could potentially lead to novel intervention standpoints from population level all the way to the individual level. And so by having a much more robust understanding of the disease and of just brain aging in general across our entire community, I believe that we can do much more. So thank you for your time.
Thank you, Dr. O'Brien. Excellent presentation. And you really, you had a lot of points that resonated with the audience here, as evidenced by the chats, and some great points I think that were underscored here. So I'm wondering, maybe we could just take one question and then we'll go on to our next speaker. And maybe Sid, do you want to address Joe's question about new ideas and the infrastructure, and getting into the, I mean, you have a lot of great themes that we could expand on here, but I think for this question, underrepresented populations and learning about how the biomarkers are performing in those underrepresented populations is key, but then there's the infrastructure of reaching them. Can you speak to that for a moment?
Yeah, and you know, as you said, I'm part of New Ideas. It's an excellent study. It recruited very well across all communities, and I think that groundwork does lay foundation for additional efforts. It takes time. It really does take time to build the trust, to build the community engagement, because going out and getting engaged in these FQHCs, in these primary care clinics, in these diverse communities, it takes time to build those connections. And then in time, I do think absolutely that infrastructure could be leveraged for additional enrollment into, because there has to be a referral to those specialty clinics or the pet centers, et cetera. And so there are ways that these things are beginning to happen, which I think is a tremendous value. And so it simply needs to be leveraged, continued, and grown and refined, lessons learned, et cetera. So I do believe there's a lot of opportunity there.
Excellent. Okay. Thanks, Dr. O'Brien. Why don't we're going to move on now to our next speaker here. Dr. Fanny Elahi. Dr. Elahi is a physician scientist and associate professor in the departments of neurology, neuroscience, and pathology at the Icahn School of Medicine at Mount Sinai in New York. It's really good to have Dr. Elahi here at this session today. She really brings that trifecta of experience in patient care, research, academia. So just really good to have you on this in this session. So feel free to drop your questions and comments in the chat, and we'll get to some of those afterwards and in our general discussion. And Dr. Elahi, I'll turn it over to you.
Thanks so much, Chris. It's a pleasure to be here. I'm a little bit worried that the same thing that happened to Ron's slides may happen to mine, because I already see the formatting to be different. So we'll see. Some surprises ahead. Thanks so much to Ron and Sid for those wonderful talks that I'm going to refer back to quite a bit. Next slide. These are my disclosures. Similar to Ron Peterson, they're not making me rich. Next slide. So some fundamentals and basics. You know, I want this talk to be dedicated to us thinking critically about whether we are ready to incorporate some of these biomarkers into clinical care outside of the research setting, where interpretation is dependent on so many measures that may not be available to us in the clinical setting, in diverse clinical settings. So there are targeted biomarkers, and genetically, I would say ApoE genotype may be one. And there are several fluid biomarkers, which is really going to be the focus of this talk. Neurofilament light, GFAP, p-tau, etc. There's another slide coming up to go through them. And the question about targeted biomarkers are we getting closer to the level of accuracy and precision that we want to risk stratify populations, and or are some of them at the point where they're clear cutoffs where we can actually use them for diagnostic classification of individuals? In patient care, it's not just about drugs, it's also about prognostication. Do they help us predict the trajectory that the patients are going through? You know, as clinicians, we often get the question of what's to come in 5 years or 10 years? Do we have any way to actually predict that speed of decline, for instance? And then ultimately, do we have surrogate biomarkers of therapeutic efficacy, which is a whole other level of validity that I don't think we have reached yet in at least the fluid biomarkers. And I really want to make a plug for biomarker discovery and ongoing work to expand the toolkit of biomarkers. And there are now very technically reliable methods to do omics that would allow us to actually expand the toolkit. And you just heard Dr. O'Brien's talk about a need for more diverse populations that we study. And also his data showing that amyloid, which has been such a big focus of Alzheimer's disease research, may not be predicting as much of the variance or of the decline in more diverse populations. So we definitely need more biomarkers. Next slide. Now, if we want to take biomarkers into the clinic, the level of biological and technical reliability is so much higher than research. These are data that the patients are gonna have access to, their clinicians who may not be specialists will have access to, and they have some serious ramifications for the delivery of care in our system. So the questions to ask are these biomarkers strongly, and strongly may be a vague, how strong is strong enough, associated with the core features of disease? And I would say that by far the most studied disease would be Alzheimer's disease. And so many of these biomarkers are marking amyloid and the amyloid-related tauopathy. Are these biomarkers associated with clinical symptoms? And you saw Dr. Peterson's talk that in non-Hispanic white, yes. And Dr. O'Brien's talk showing that not as much in diverse populations. Are these specific to the disease, and are they sensitive? And I would say that recent studies have shown that maybe the plasma biomarkers are actually potentially even more sensitive than the highly validated PET scans and potentially even CSF. The technical reliability, again, for biomarkers of Alzheimer's disease is much further along than any other biomarker. And so from that perspective, I don't think we have any worry that the measures are technically unreliable. Next slide. This is a really lovely study from the UC Davis group showing that if you look at brain tissue from diverse patients, then you have cerebrovascular disease all over the map, and the AD only cut of the figure is actually quite small. So we know when we go to brain tissue that we are ignoring a large part of the burden of pathology when we just focus on AD neuropathological changes. So it's really paramount to be able to detect the other components of someone's disease and decline, clinical decline, with non-invasive, scalable, and cost-effective fluid biomarkers. Next slide. So I would say the most validated biomarkers in plasma, which the blood-based biomarkers are really the game-changing biomarkers, are neurofilament light has been around for a long time. It is measuring axonal degeneration, so not specific to any given pathology. And in fact, every neurological disease that's affecting degeneration of neuronal axons is going to elevate this biomarker. It has some really, really great utility in that it is disease agnostic or category agnostic. GFAP, which is capturing astroglial activation, and I think some recent data is showing that it goes way high in Alzheimer's disease, maybe more so than other disorders. But again, it is another sort of disease agnostic biomarker, potentially higher in disorders that are affecting astrocytes, which a lot of things do. And then interestingly enough, the hyperphosphorylated tau biomarkers are actually capturing AD tauopathy because in blood, because they get released and can be quantified at higher levels in AD. The primary tauopathies are not benefiting from these blood biomarkers. And this is a really important point. There's also the A-beta ratios, but we know from a lot of studies that p-tau is performing better as a predictor of amyloid than the A-beta ratios. And just a shout out to some emerging biomarkers that are non-AD focused. One is the cryptic peptides that can be detected in TDP-43 apathies, and then some emerging, and this thanks to a lot of funding from NIH, NINDS, and NIA, and a shout out to Rod Corriveau that has made so much funding available to develop biomarkers of microvascular disease, and some really interesting papers out there and more coming out to show how prevalent the elevation in these levels can be across disease categories. Next slide. So p-tau, and this is p-tau 217, is by far the most validated biomarker. Again, it's a really great biomarker of amyloid burden in the brain. And this is a proposal, a collaboration among many teams, saying that we could potentially use this as a screener, meaning that if you're above a certain cutoff, you have a very high probability. Now, if that means that you're going to get treatment, then you do the more advanced, PET or CSF testing to get a definite diagnosis. And or if it's for clinical care, that may actually suffice. Then you have the low risk group in blue. But I will show you some data, and you've seen this, but pay attention to the amount of overlap between amyloid PET positive and negative, or CSF PET positive and negative individuals. That middle group is actually quite large, which leaves me uncomfortable to use these plasma biomarkers by themselves at the N of 1 level. And I think we need a lot more work and potentially have a panel of biomarkers that allow us to have a higher accuracy of classification at the N of 1. Next slide. So this is the granular data that I was talking about. And I think any paper or any data set, we ought to look at this. And I'm going to add that adjusted or unadjusted models have as much overlap. So if you look at cognitively normal individuals in non-Hispanic, white, African-American, Hispanic, or Asian, in this case, it's mostly Chinese research participants, you don't have significant differences in the means of the group means. Similarly for MCI and dementia. But then when you look intra-group, you see that by far the most significant increase in levels of p-tau in clinically normal, cognitively normal individuals and MCI dementia is in non-Hispanic whites. Now, I would really like to underline the fact that these are really small sample sizes. Maybe if we look at thousands of individuals, such as in the data set that Sid has assembled, it's going to be completely different. And this is a huge gap in our field. Next slide. The other thing that's really important is that you have cutoffs, that's one thing, but then are levels significantly associated with clinically meaningful outcomes. Now, CDR Sum of Boxes is a research measure, and I think we have not yet implemented systematically across the board outcomes that are quantitative and are capturing the most meaningful aspect of decline for patients. And yesterday's talk was really exciting because I think a lot of things are in the pipeline and we could do a better job to capture what patients care about. So if you remember the prior slide, the difference between cognitively normal and MCI and dementia was much greater for non-Hispanic whites. But if you look at the continuous association of these biomarkers, the R squared, the variance explained in the clinical outcome, is by far more important for the Chinese subgroup than the non-Hispanic white. Next slide. I'll go through this quickly, but we also used MoCA and other cognitive outcomes, and the directionality is congruent. But I think MoCA is less generalizable across ethnicities and subgroups. And I like CDR Sum of Boxes more for that. Next slide. So you saw this in Dr. Peterson's talk, but I'm really struck by this. And I think this is a big problem, because what I worry about is that we now have p-tau 217 and other p-taus that are so incredibly reliable from all sorts of perspectives. I don't want us to get shooed into going after amyloid more and more because we can detect that. Here you're seeing the huge decline in amyloid burden and the rather modest, comparatively, a slowing in decline that Dr. Peterson broke down even further in clinical outcomes. And so really what we are currently capturing with the highly validated biomarkers is the tip of the iceberg. I'm adding cognitive decline also in the tip of the iceberg because we know that there are a lot of psychiatric symptomatology and other things that we don't have good quantitative measures for that are part of the early stages of disease. So expanding the toolkit is absolutely critical in order to have true impact in the clinic. Next slide. So I mentioned microvascular pathologies. That's my personal scientific bias. This is what my lab is really focused on. But related pathways and abnormalities are cholesterol, lipid metabolism, hugely important for Alzheimer's disease, potentially synucleinopathies and others. Immune response is probably going to be a component of all disorders, and yet we're not capturing that adequately in research populations and or patients. All aspects of immune response may also differ. And then finally, at the heart of brain function decline is synaptic plasticity and changes that we're not able to detect in blood yet. Next slide. You heard about the medical comorbidities that matter to the cutoff and the use of these biomarkers in real world diverse cohorts. And I think this studies ongoing right now are going to shed light on this, but it will be very important to have algorithms that allow us to interpret the levels of biomarkers accurately in diverse populations from all sorts of perspectives, including medical. Next slide. So, one thing to consider is that we have genetic ancestry, and you heard about the ApoE differences in various genetic ancestries. There's also ethnicity, and ethnicity is very complex and a true component of someone's life and experience. And so we need better ways to quantify the various components and incorporate into these incredibly sensitive biomarker models that we build. We have molecular measures that are really sensitive, and everything else, I think we don't do a good job of capturing and entering into the predictive models. Next slide. So you heard a lot of next steps and important gaps, and to add a few or perhaps reiterate some important ones, we need real world data, meaning not the research participants. There's always some sort of bias with regards to who is willing. So get out in the community and do the hard work of enrolling individuals who may not come to the research by themselves. The components of race and ethnicity are complex, and we need to capture that better. There are many biomarkers that need to be developed. At this point, I would say neurofilament light and GFAP may be the least biased. We know that p-tau is biased towards amyloid positive tauopathy. And then finally, we need vascular biomarkers for sure, but one really hard aspect of vascular is that it's not one disease. I think we need to capture dysfunction from the blood-brain barrier. We need to capture the vascular fibrosis, hypoxemia, the pathological immune interactions. There are many components of microvascular disease that we know are contributing to neurodegenerative disorders that we currently are not able to capture. And then a thought about how we want to use these biomarkers. My personal pitch is that I can see a time where we incorporate fluid biomarkers similar to how we do lipid panels or kidney function. And we look at intra-individual trajectories, and we don't have stigma about neurodegenerative disease and dementia. And there's this sort of lack of fear. And we do it on an annual basis. And when someone's levels are trending in the wrong direction, we do something, and we have a lot of options. I think the cutoff values, we're not there yet. We and others are studying this in clinical settings, but we always go back to the more understandable cutoffs for PET scan and CSF. So this is really something that I would love to discuss with all of you. And thanks for your attention.
Thanks, Dr. Alaei. Great presentation and great take homes too, giving us a lot to think about here. I think we have time for one question before we move on. Did anybody want to? I'm just looking through the chat. I didn't see anything directly for your presentation. A lot of great comments. Great presentation. Just wondering. Here we go. Ryan Muir. What are your thoughts on 1, diurnal variation on biomarkers, 2, variations with food intake, even confounds by medications used, collection methods, and standardizing that?
Yeah.
Your comments on that?
Yeah, I think we and others have looked at some biomarkers, and things like neurofilament light and GFAP and even p-tau to a certain extent don't have important enough diurnal variation, but inflammatory biomarkers, metabolic biomarkers, and other biomarkers actually do. So I think it's going to be biomarker specific, and it is absolutely something that needs to be looked at. Now, the samples are not there. So this is something, we need to have banks that allow us to ask these questions. And similarly to the point that was raised before, it's all in the design, because if we don't have the samples, we'll never be able to ask these questions. So good to incorporate this in the design of studies.
Excellent. All right, thanks, Dr. Elahi. And we will move on now. And next, I would like to introduce Miss Sarah White. Sarah Walter. She's the program administrator for, program administrator for the Alzheimer's Clinical Trials Consortium, ACTC, and for the Alzheimer's Therapeutic Research Institute, ATRI, at the University of Southern California. And in her role, she works in the whole spectrum of clinical trials, from participant recruitment, conducting assessments, clinical monitoring, and she will be interviewing Ms. Barbara Bostad. And I'm going to turn it over to you, Ms. Walter.
Thanks, Chris. Appreciate it. And I just want to thank the organizers for including research participants and community members in these conversations. It's so important. And I know that we as researchers get so much more out of it than we ever expect. I also want to thank our ACTC Research Participant Advisory Board. A number of them are here today, and they have been very active in the chat, challenging us to dig deeper, to do better. And so I want to thank you all for your incredible commitment to research. Many of you are working full-time jobs, providing care for loved ones with Alzheimer's disease and other dementias, and you still take time to show up for 3-day workshops. So thank you so much for all of you for being here. Just looking to see if Barbara's been able to turn on her video. There you are. So it was my pleasure to meet Barbara Bostad at CTAD this year. Barbara is a research participant in a number of studies that she'll tell you about. And we got to know each other at CTAD because our Research Participant Advisory Board asked us to include them in these scientific venues. They want to hear firsthand what's happening with science, and they want to have the opportunity to tell you what they think about it and what's important to them. So again, thank you for making time for this, to the organizers, and thank you, Barbara, so much for making time in your day and your week to be here today to tell us more about your experience. So Barbara, can you tell me just a little bit about your background, your experience with Alzheimer's disease and dementia?
Sure. We'll start with greetings from Madison, Wisconsin. That's where I am right now. Beautiful Madison, University of Wisconsin. My name is Barbara Bostad. I am honored to be here with you today, and I'm really excited about sharing my experience as a research participant at the Wisconsin Alzheimer's and Dementia Research Center. And I would like to extend so much appreciation to you, Sarah, for all of the things you have been doing, getting us to Boston for CTAD, and all the things you have helped us with as a group and as a panel for this conference. So a little bit about me. I was asked to give some introduction and context. I'm an African-American woman, 72 years of age, married with a blended family that includes 4 adult kids, their spouses, and 3 grandsons, ages 4 and 2 years old. I am an active member of Christ the Solid Rock Baptist Church here in Madison, and I have a deep spiritual belief and connection with God. I retired from clinical social work in 2016 after 40 plus years. I see myself as a clinical social worker. I will die as a clinical social worker. So retired is just that name they put on me. And Sarah asked me actually to mention that I published my first book in 2020 called From 50 to Fabulous, pivoting to a life of joy and purpose, part memoir and part highlights just about how to maneuver life and how to work through challenges after the age of 50. So I'm kind of keeping to a script because I can go into a lot of detail. So I will keep to what I'm here for. In 2011, I started a daily money management business, which I called Mary's Daughter, after my mom. And I started helping older adults with their money management. And some of those I found were referred to me from the Alzheimer's Association because that's what they were struggling with. And so I started working with them as a daily money manager. And I really enjoyed that. But I felt like, as I do with all my social work opportunities, I look forward to learning more about my clients and how I can help them even more. So that's when I started doing a deep dive into the Alzheimer's Association and what I could learn about it. And I started working one of my first clients named Jay, and he was in his late 70s, and he was having problems managing his money. He wasn't diagnosed then, but his son asked me, and the son's wife asked me to kind of work with Jay on helping with his money. And I started seeing the deterioration and realizing we needed to get more support. And again, I reached out to the Alzheimer's Association as well as the family did, but there was a lot of resistance to that. They did not want that diagnosis. They did not want to hear about that. And the stigma, which I understood, but I hadn't really appreciated until then, actually working with someone and their family. And so again, I'm thinking about Alzheimer's and learning about it, but then I got hit with one of my close friends through my husband. We were on vacation and we were told she was diagnosed with early onset Alzheimer's. Her name was Kathy, and she's in the photo there on, in the Canadian Rockies, very active, vivacious. She did so many things and she was so active. And then we were in a week, spent a week together in Cozumel, and the impact, this is early onset, but the memory issues and the problems, and I just, how could this happen to her? Again, I had my client over here, but this is someone I knew in my life that I cared about. And so then that hit me hard. I said, I got to do something because this is happening to people around me. I was not diagnosed with Alzheimer's. I did not have that in my family, but this is happening. And this is happening to people that I would have thought never would have this happen to. So I started getting involved with the Alzheimer's group, and they were great. They helped me so much because they said, come to our workshop, Barbara, do some workshops, get involved. And I went to one of the pictures there is in 2014, I did the Alzheimer's walk. And Kathy, Cody, we called her, was the person I walked for. Fatou Cisse in that picture on the right and Bonnie Nutkinson on the left gave me lots of information and helped me really get a good understanding. And then I started meeting people like Dr. Sterling Johnson, Dr. Terry Gleason, Dr. Cynthia Carlson, and they were so wonderful. So I don't want to keep go off script, but I just want to say I got very involved, and I really wanted to be someone that could be of help in some way. And so being a research study participant, which I initially wondered about because I didn't want to be poked and prodded, even though I believe in research. I told Sarah I was involved with the Black women's history study, Black women's study in Boston, a health study for 25 years. But they didn't prod me with needles or anything, or poke me, or do lumbar punctures, or do PET scans. So I was okay with them. But anyway, I was able to get involved in a way and thought that I wanted to do some more involvement. And I don't think I want to continue on until I let Sarah jump in here.
Oh, no, I'd love to just hear a little bit more about that decision. I mean, you mentioned to me before that it took a minute or even months for you, even though you were already in another research study and you had the background in social work and you had that personal experience of, seeing somebody live with dementia. It still was a tough decision to take part in research. And I think just thinking back on some of the comments made in yesterday's panel and even earlier today, can you just talk to us about what was it that motivated you to actually take that step towards research?
All about relationships. It was all about relationships because I started going to some of the discussions, the brunches that they had. UW Alzheimer's Research Center is so wonderful, and their outreach, Dr. Like Charlie Daniels, Dr. Fabu Carter, they really encouraged me to think about it. I didn't feel pushed, and I just found my certificate of appreciation, which you may not be able to see it, for becoming a brain donor. I was just going through some of my Alzheimer's papers, and since August 17, 2015, and it took me a couple of years to think through this and think that that's what I wanted to do. I didn't know anyone who had done that before, but I met the group that was involved with, getting the UW group. And I just said, if this is important, like to Fatu, if this is important to the people that I get to know and I've learned to trust, that was it too. I learned to trust them. They were very transparent with some of the studies, successes, challenges, failures. So I felt like I can trust people. And yet it was still tough because it went against, what I had grown up with in terms of, for instance, brain donation, MRI, getting a CAT scan or an MRI or PET scan. What are they injecting into you? I mean, some of that old bias stuff is still with me. So I had to fight against that. And I could only do that in community of people who were doing this. The AFAM group, the African Americans, midlife, preventing Alzheimer's in midlife. That group has been so wonderful because we talk about this all the time. The ADRC, they put on a Solomon, Carter Fuller brunch every year. So we sit together and just talk about the research, talk about the updates, and get treated to a beautiful lunch, brunch. And we meet great people. We meet the scientists, the researchers, we meet them and develop relationships with them. So that's what got me over the hump.
Thank you, Barbara. I just want to open it up now to our other panelists, to Sid and Fanny, to join in this conversation and maybe connect all of Barbara's rich experience to this topic of biomarkers.
I'd like to I'd like to throw a question to Barbara.
Can't see anyone, but go ahead.
I'd like to hear your thoughts, Barbara, on the whole notion of bringing the research to the community, getting out of that ivory tower, and giving presentations and just being present in the community from your standpoint and your experience. How is that received, and what do you think is it really as meaningful as I seem to think it is?
Well, Dr. Brown, let me say to you, as you were speaking, I was like high-fiving, hallelujah, amen. My church was coming out of me. That is exactly what we're looking for. We are really talking more and more. In fact, in Madison, we actually have satellite programs now. So I meet at the partnership, on South Park Street, on the south side of Madison. We have our exercise class. We have our get-together nutrition class. It is wonderful. We get out in the community. There are at churches that have Mount Zion. We have a computer jitters class if you don't like working with computers, and that is we meet at the church. So definitely, and we talk about having access to a nurse or a medical practitioner who will be able to do blood pressure and things like that. So I am all over that. That is really what we love and talk about. At the Black Leaders for Brain Health, where I'm a member, and Dr. Alex G is the head, we talk about that all the time as part of that group. Dr. Diane Gooding, is wonderful. And we have such great researchers on the team that we always say, come to us, because going to the ivory tower, going to the UW hospital, it's a maze, it's huge, it's a labyrinth. And being able to be in the community, blood pressure goes up when people have to even park. So I am totally on board with that. And I know our group, AFAM and the RAP group and the core program, all of those folks are so excited. I think in Green Bay, there's going to be for Indigenous folks as well, who are way up there, and rural folks who aren't able to come down to Madison. So we're doing it, and I'm really excited that we're able to offer this more. It's still evolving, but it's really important. I agree.
And Ron, go ahead. You had a question?
Sure, just had a quick, Barbara, thanks so much for your insightful comments. You mentioned something in your response to Sid that I'd like to follow up on. How important is the return of results? That as we collect all this information from you, biologic markers, clinical markers, that's really important, isn't it, to engage you and to keep you involved in our research efforts?
Yes, it's very important. However, I think the Bill of Rights that Cynthia had mentioned before, that I think we've seen is important. There are some people who are clear, they do not want to know, but they want the option, and their family member and caregiver who are, providing that support want to know. And so it is very important, because anything that's withheld undermines that trust. If we think that you're holding back something, what are you holding back? Why are you holding it back? Shouldn't we know what's going on? And even if we choose not to accept it, again, referring to the Bill of Rights, having the ability to have that makes it feels like you're not just taking from us, you're giving us something back that is valuable to us. So thank you for that question.
So the option is the most important. Yeah. Okay. Thank you.
I'm going to go ahead with my question, and then Fanny will go to yours too. Ms. Bousted, thank you so much for being here and your perspective on this. This is very, very encouraging. And one of the things I just wanted to ask you was, I work with a lot of industry partners who are would like to be more involved with the community. And one of the things that you had said is about the relationship building with the community. So what advice from your perspective would you have from about somebody who wants to conduct research, but yet doesn't have that community connection yet, but would like to establish that relationship? Where would they start?
It's interesting, because really being able to decide what is important for that person, that individual. Is the spiritual community a place they'd want to start? Maybe it would be the ADRC, which is Aging and Disability Resource Center, not the Alzheimer's, but and what is it that you might want to offer? Maybe classes. There's a podcast that I think Dr. Nathaniel Chen, has a podcast out there. We love it, being able to listen to him talk about some things and have speakers. There are opportunities, panels that Wisconsin has, Alzheimer's Association, many things in the community where people come out and then they are present. They're a part of that. So being able to attend those, again, based on one's comfort level, and being able to say, I'm coming to learn from you. I mean, that's key. I'm not coming to take from you and give you results. I'm coming to learn from you because I'm interested in the community and the well-being of everyone around here. So how do I support you? And then in supporting, in offering that, I mean, particularly if you're authentic, intentional, and really want to be, want to do it. Because some folks, you may get a rebuff and it's like, no, I don't want you near me. And that's okay. You have to be willing to continue that and be able to, and I think be also understanding that there is going to be a history of trauma, a history of distrust, a history of who's now coming to get something from me. So if you get no, we don't want you here, don't give up.
Excellent. Wow, great points. And I know the leadership of this this workshop has definitely heard those points. And I know those are that's a great list. Thank you so much. Dr. Lottie.
Thanks so much, Barbara. I really enjoyed your talk. So following up on the question that Dr. Peterson asked, I just want to get more clarification. I think I have, as a physician scientist, always wanted to share results with the patients, but I also understand as a scientist that there are layers of the onion that we're peeling off, and our understanding advances, about how to interpret these biomarkers. And one of the things that is a point of discussion often is how much uncertainty can we communicate to the participants and the patients. So the blood biomarkers are not where PET and CSF are, but if we don't do it, commercial entities that may do less of a clean job will offer these biomarkers sooner or later, and some are, to direct consumer ordering them. And I feel that we have a lot of hesitancy, rightfully so, that we don't want to do harm, but as a result of it, there's this sort of lack of communication. So I often get this from the research participants. They want to know what I know, what I've seen on their brain scan, but also their blood biomarkers right now. So tell us when, how uncertainty is perceived. If we can just communicate to the participants that, look, we don't know exactly where you fit and how much risk, but
that reminds me, as a clinician, I'm a private practice therapist for a lot of years, and clients sometimes would want to know their diagnosis and what does that mean? And I had to make a determination because I would have that information, but could they handle it? And so I would talk about, what is it that you're really looking for? What is it that you really are needing at this point? And how does that help further the cause that that you're asking me, for this information? And again, not doing it in a, direct question, but like more of a conversational tone. Tell me more about, how that would help you or not help you. Let's talk more about what you're really looking for. And for some people, it's, I just want to get my kids prepared. So what might happen? So I just need to know what it looks like. And so to me, individualizing it based on your knowledge of the individual, the person in front of you, and also what they're really asking. Because sometimes what they say, I want to know the results, isn't what they're really asking. And so being able to get that next layer down, and I hope that's not being too my clinical background, but it really does mean that you look at what the person is really wanting from you versus assuming that it's a cookie cutter. Oh, they want the test result. For some people, just like when I did money management, they didn't want me to put together a nice spreadsheet of what there is. Do I have enough money to last? That's what they want to know. Okay, yes, you do, or no, you don't. You got to stop spending over here. And we could avoid all the other, information, all the other specifics, because what they really wanted to know was that bottom line. And to me, that would be the question I would try to get them to come up with, or the phrase the question, what really is it that you're looking for? Because I have this, and how do we work together so that you get what you want and not just a bunch of numbers?
Yeah, so I hear you that we need to personalize the communication of these results just as much as we're personalizing their quantification. Thank you.
I think so. Yeah.
Maybe Ms. Walter, do you want to have any final words or thoughts before we kind of open it up? We'll bring all of our presenters, speakers from session 3 back on, but I wanted to give you kind of the last word.
I don't know, Barbara, if you're comfortable with me pushing you a little bit on the sharing of results, but you've been involved in so many research projects. Has there been a situation where you didn't learn something that you wanted to learn personally? Or were you able to, were you given the choice? What was that like for you?
That's a good one, because it's interesting because I did not know about getting the results. We get an option to get a follow-up phone call. And so the follow-up phone call has usually been, well, things look good, Barbara, or you're doing well, whatever. But after this conference, I want to know more. I want to know more about some of these tests that I'm taking. I'm more, at this point, I have been, I have a lumbar puncture and I hear that's clear, and MRI, but, or I haven't done the PET scan yet. Now I'm eager to go for that. I mean, I really want to be more involved that way. And so part of it for me has been, maybe I don't ask the right questions. I'm so eager to hear, Barbara, you're okay. I don't want to go any further. But maybe I now need to ask them the questions, because I'm actually feeling some of the concerns in terms of memory. You know, I have to write down lists now. I have to do certain things. Is that part of aging, normal, or is it something else going on? So I'd like to have more of that discussion so I myself can prepare as well. So that's great. Thank you for asking that.
Absolutely. Well, I just want to thank.
Oh,
sorry.
Go ahead.
Okay. I just want to thank you for being here again and for sharing your story with us. And again, to our participant advisory board that's again active in the chat, and looking forward again to tomorrow's conversation where we hear from a few others about their lived experience and what they'd like to see change in research. Thank you.
Thank you.
Thank you so much, both. Okay, we're going to, I guess, open things up now to our audience if they have other questions for any of our speakers right now. And Luke, correct me if I'm wrong, or do we got about 5 minutes, right? Before we have a scheduled break in about 5?
Yep.
Okay.
And just to note that we have shared Dr. Peterson's slides with the correct format in chat, and apologies again to you, Dr. Peterson.
Thanks, Luke. That happens. No problem. Chris, may I ask a question?
Go for it. Yes.
Sid, you nicely pointed out that some of the upstream Alzheimer's disease biomarkers do not necessarily translate to downstream, or in a broader range of participants with less dynamic range and socioeconomic factors, the Alzheimer's biomarkers look to be more important. When you have the wider dynamic range from a variety of participants, it's less so. But would there be some downstream biomarkers that still might be relevant? Neurodegeneration, isn't that sort of a compilation of, Alzheimer's factors, vascular factors, whatever factors? Now, I'm not sure we could pick up the social factors as well, but do you think there are some downstream biomarkers that might actually be more reflective of cognitive function going forward in broader populations?
Ron, that's a great point. And I will say that at the moment, what we are seeing is that neurodegeneration seems to be the biomarker most consistently associated with cognitive outcomes. Yet what's leading to the neurodegeneration, right, is what seems to vary. One of the things we are trying to dig into a little deeper is really, are there subsets of individuals where amyloid is really associated with cognition across and et cetera? The downstream right now, it does look like neurodegeneration appears to be more consistently associated with those outcomes. And even potentially more consistently associated with some of the, like the medical comorbidities, et cetera. So it's like non-specific, but very sensitive is so far as what it's looking like.
Yeah, good. Thank you.
I don't see any other hands up, but feel free to raise your hand, come off mute, and ask questions here. We've got a few minutes left. Anybody else? I do have one other quick. So one of the things that I guess I posed to our speakers is that one of the themes that came up here was, and was in the chat as well, I saw many comments about the need for infrastructure for the longitudinal data that we desperately need to help understand the biology of Alzheimer's and how our biomarkers are performing here. So research, clinical care, this infrastructure. And I'm wondering if any of our panelists would like to just sort of opine on that in where do we go? What is the most important thing? One of the things the Alzheimer's Association's doing right now is we have the ALZNet treatment network for FDA approved treatments for those diagnosed with Alzheimer's. So we are, in having that network to collect that data and to also make it available for the community to help advance treatments and diagnostics. And I'm curious what other things you all see as important to develop this as we go forward.
So Chris, just, so there are ways to leverage, for example, FQHCs and other. I think we need to think more broadly, because oftentimes individuals from underserved communities don't have primary care. And so when we go to clinics, we are absolutely, even a primary care clinic, we're selecting specific individuals. A lot of individuals from underserved communities get primary care at the emergency room and at urgent care clinics. And so I think we need to think about, we need a multi-pronged approach. We truly need more community-based outreach, engagement, larger networks, et cetera. Then we also absolutely need those clinic-based infrastructures. I think we need to think primary care and FQHCs and other components. How do we get to the clinics that are actually seeing these participants?
Yeah. And I think building on that, I 100% agree. I think people who even make it to clinic is a slight bias, smaller bias than research cohorts for sure, but still a bias. One of the things that we've started doing, and it's in the early stages, so we don't yet know how well it's going to perform, is to do mobile phlebotomy. But I think ADNI-4 is also doing that. So go to the patients. Now, that is going to be dependent on how good the remote assessments are going to be as well. So I paid a lot of attention yesterday, and I'm not sure that we know yet which assessments we can implement across the board. And I think it's really interesting. It would be really important to have similar assessments that are sensitive to various kinds of backgrounds, but that are robust enough. And we need to at least have some things in common that we all start implementing and quantifying. But so far, from a patient perspective, the mobile phlebotomy works beautifully. Patients are actually really, or research participants are happy. They get to schedule it when it works for them in the comfort of their home. And the phlebotomists are really experienced, at least for us. Yeah.
Thanks, Dr. Lai. So Suzanne, if you got a quick question, we're going to give you a quick answer, and then we're going to go to break. I want to make sure we give people a little bit of a break before we start again at the top of the hour.
Yeah, I hope it's pretty quick. So I've heard that one of the most underrepresented populations is rural populations, which of course includes ethnic and racial diverse populations. And I think a lot of what we think about is how to target people within urban populations or nearby suburban. How do we reach out to those communities and see, you know, representation across racial and ethnic groups as well within those rural populations? Any research around those specific populations?
Suzanne, this is Ron. I can comment a little bit on that, since we live up here in the hinterlands in Minnesota, and we are focusing on the rural population, and they may actually have an important element that's been missing from almost all of our research participant groups, is lower education. If you cut across, even if you take people who participate in research studies for Hispanic, African American, they tend to have higher education. So really, lower education is one of the common factors that we've been missing. And I think getting at the rural communities is one way to make some headroads into that.
And is anyone familiar with published research in that specific population?
Yes, there are some publications in rural. There was a previously generated study called Project Frontier that's no longer up. But there are other things in there. There are groups now building to work towards rural. We're actually looking at trying to expand HABS-HD into rural as well, and there are other groups working on that. So that is an initiative that folks are starting to look at, and you know, it's very important, and we need to do more of that. I agree completely.
Thanks, Ron and Sid. That was really great.
So thank you, guys.
Right.
I'm going to close. And Barbara gave a shout out to social workers. I want to give a shout out to community health workers. My wife is a nurse practitioner in a federally qualified health center. So I appreciate the service in-house in a very real way. So we'll be back at 1 with session 4 on payers, regulators, and health economics. So enjoy your break.
Thank you, everybody.
Okay, so welcome back, everyone. We are starting with session 4, and Priscilla.
Good afternoon, everyone. Thank you for being with us for this session, in which we will talk about payers, regulators, and health economics. The moderator for the session is Dr. Joseph Hutter from the Centers for Medicare and Medicaid Services. And we're also joined by Teresa Baracchio, who will provide a few comments now.
Okay. Hi. So I'm going to start off by just giving a regulatory perspective on clinically meaningful change in clinical trials for Alzheimer's disease. So in order to receive traditional or full approval for a product, FDA must determine that there is substantial evidence of effectiveness for a clinical benefit of a drug for any given indication, and that the benefits outweigh the risks. In order to establish a clinical benefit, the common methods are either to use a clinical outcome measure that has been found to directly measure how a patient feels, functions, or survives, or a validated surrogate endpoint can be used if it has been established to predict clinical benefit for a patient. When we talk about clinical outcome assessments, these fall into 4 categories, and these may have already been reviewed in prior sessions, but I'll just touch on them briefly here. That there can be patient-reported outcomes, or PROs, clinician-reported outcomes, or ClinROs, observer-reported outcomes, or OBSROs, or performance outcomes. And the selection of an appropriate outcome assessment for a clinical trial should be informed by the symptoms or aspects of the disease that are important to patients, caregivers, and prescribers. It's important to note that for these outcome assessments, that these need to measure a direct benefit to the patient in order to support an FDA approval. Although we do recognize at the agency that the importance of the impact of the disease on caregivers and family, and that also there is tremendous economic and social burden with these diseases, the determination of substantial evidence of effectiveness for a drug must be based on a direct measure of the clinical benefit on how it directly impacts the patient. Payers may have different considerations, and I'm sure we'll hear some of those different considerations today from our panelists. I do want to mention that the agency strongly endorses patient-focused drug development, and we have a series of 4 guidance documents on patient-focused drug development that are intended to facilitate the use of systematic approaches to collect and use robust and meaningful patient and caregiver input that can better inform medical product development and regulatory decision-making. I do believe I heard someone reference these guidances yesterday, and I do want to stress the importance of this guidance series when we're thinking about developing clinically meaningful outcomes. If you are not familiar with this guidance series or you have not read it, go and read it tonight or as soon as you can. It is a really important guidance series. I'll also note that the agency recently updated, as of this week, actually, it came out on Monday, we updated our guidance on drug development for early stages of Alzheimer's disease, which we define as prior to the onset of overt dementia. And this guidance does discuss the selection of endpoints for clinical trials in these early stages of disease. And I also do want to put a plug in for another guidance that we have on how to handle statistical analysis of multiple endpoints in a trial. I'm going to provide links to all of these guidances in the chat so that folks can look at them later. After you listen to our panelists, we'll give them our full attention, but they'll be a good resource for you later on. And with that, I'm going to turn this over to Joe.
Okay, thank you very much, Teresa. Looking forward to those guidance documents in the chat. I'm just going to say a few words, excuse me, on the CMS role in all of this. And I'm based on yesterday's talk on glucose, I'm taking a little glucose spike right now in orange juice. So while the FDA ends with clinical efficacy, we start there. Generally, FDA goes first and sets the foundations on which we build the national coverage determinations, or NCDs. And these, along with coverage with evidence development, any questions that come from there, all boil down to the same thing. For us, it's all about clinical utility. What does that mean? Does use of the intervention, whether a diagnostic, device, or here a drug, improve health outcomes for Medicare beneficiaries? If so, which patients, when in the course of disease, and in what care settings? Finally, what is the durability of these outcomes? Does the benefit-harm profile change over time? So these are basic questions we are always asking anytime any device comes before us seeking a national coverage determination, whether it ends up in CED or not. When the evidence on these questions seems promising but incomplete, we can use CED, and as the world has seen, we've used it rather creatively in this case. Now, a patient, I think it was Cynthia, stated yesterday that she could not get into some trials. Our CED is actually less restrictive than any of these pivotal trials. That's in part how we get to that bigger question of generalizability in broader patients who may have more comorbidities and more general community practice. And that's something we could then discuss offline if you want to circle back. Julia, I'll let you introduce the first speaker we have. Sorry, Teresa, back to you.
All right, I think, well, we were going to have the GNO slide up, I believe.
That's right.
Okay, so I think our first speaker is going to touch on the point number 1 here, which is about the development of a patient care partner reported outcome that could be kind of standard clinical trial measure. We do have measures of function, cognition, and behavior and health outcomes, but no patient or care partner based outcome that has been widely accepted and integrated into trials. Joe?
Second gap or challenge, and this is presented by one of our speakers on the panel, is how to afford new drugs and digital interventions, even if they're FDA approved, for an increasingly aging population.
Teresa, I think you're on mute.
Thank you. Can we go back? Okay. The number 3 objective will be discussion of development of measures and models that quantify the short and long-term meaningful health and financial benefit of treatments, which could be used by various stakeholders. Okay, we'll turn this back to the moderators now. Or are we turning this over to Jeff now? Are we gonna?
That's okay. Sorry about that. That was my confusion. I messed up on the. I forgot we were getting the geo slide in there. So our first speaker today is Jeffrey Cummings. He's the Chambers-Grundy, the director of the Chambers-Grundy Center for Transformative Neuroscience at the University of Las Vegas. He's going to speak about assessing meaningful change in clinical trials. Jeff, go ahead and take it away.
Great. Thank you, Joe. Thank you, Teresa, Nicole, Luke, NIA, NINDS, everyone who brought this together. It's been fantastic and quite different yesterday and today. It's been really great to see the diversity that we have brought into the discussion. Next slide. So these are my disclosures. I've consulted for a large number of biotech companies and pharmaceutical companies to try to help them develop the best possible drugs for Alzheimer's disease. Next slide. So I'll discuss why clinical meaningfulness now. Why are we having this discussion? I'll look at some definitions and some measures. I'll look at the difference between disease modifying and symptomatic treatments, because that's an important part of our discussion now. I'll quote a few observations from clinical trials from the anti-amyloid monoclonals, because they are informative of this discussion. And then I'll end with what matters most to patients and the patient's Bill of Rights. We heard some of this yesterday from Dr. Riley. That was a terrific discussion. Next slide. So why meaningfulness now? I think this is important. Neuroscience translational success has occurred. It's really great that we have had new approvals for Alzheimer's disease, for ALS, for Friedreich's ataxia. We're in a new era. And we have to think about meaningfulness in a new way. This balance, we've realized, between efficacy, safety, and cost of the new therapies has many stakeholders, and that's one of the reasons that we have many voices in this discussion. And concepts such as clinical meaningfulness or meaningful benefit must be adjusted to account for disease-modifying therapies, because they differ from those from symptomatic therapies. A larger point is that society and healthcare systems require the flexibility to accommodate new and emerging therapies. The new therapies are not the end. They're the beginning of many new therapies to come for patients with neurological disease. And I'm confident that there will be no single measure of meaningfulness that incorporates all stakeholder values. I don't think the end product of this discussion will be a number. This discussion will lead to a perspective that I think we'll need to bring to bear on many types of outcomes. Next slide. So let's look at the measures and the analyses of meaningfulness. Clinical trial outcomes include conventional measures addressing cognition, function, behavior, and global function. We've seen a global measure, the CDR, in the discussion with Dr. Peterson this morning. Of course, we have fluid biomarkers, imaging biomarkers, and digital biomarkers that are increasingly important in understanding the biological impact that our drugs are having in clinical trials. We do have measures of quality of life for both the care partner and the participant, and they were an important part of the discussion yesterday. And they come closest, I think, at this point to capturing meaningfulness for the patient and the care partner. We're going to be discussing health outcome measures. And as Teresa noted in our GAP slide, that patient-reported outcomes and observer-reported outcomes from caregivers are not very well developed in the Alzheimer's disease or the ADRD area. So that's an area of gap and opportunity. Now, when these data are collected, they are then subjected to various types of analyses, and it is those analyses that give results that we conclude whether or not these changes are important to us. And these might include effect size or responder analyses, the numbers needed to treat versus the numbers needed to harm, a commonly used outcome strategy for payer organizations. Time to event and time saved were presented yesterday by Suzanne Hendricks, really important concept. Another important concept has been the minimal clinical important difference. I like this measure a lot, but I think the name could be reconsidered. I think it is really about the minimal clinical detectable difference. And then we would decide in other circumstances with another vocabulary, whether or not that was an important change or not. Transition probability, and Ron showed us those transition probabilities in the community for the diagnosis. We can use them in clinical trials as well. Quality adjusted life years are important, and reasonable and necessary has been a standard from the CMS, and Joe may comment on that. Now, with the emergence of DMTs, we've seen a couple of other types of measures of benefit, such as cumulative benefit, because there's an increasing drug placebo over time, or predictive benefits, because we know that changing a biomarker may be sufficient to predict a future clinical change. Next slide. So just to remind you of this difference between symptomatic therapy on the left and disease-modifying therapy on the right, and Suzanne showed us similar strategies yesterday. So the patient improves and has a delay of milestones that is standard across the therapeutic period in symptomatic therapy. And in disease-modifying therapy, there's a change in slope. There is no improvement above baseline. This is an important point. And there is increasing drug placebo difference over time. Next slide. So we can look at the vertical difference on the left, the change in slope, the increasing drug placebo difference, and note that the MCID would be a point in time. So it works better for symptomatic measures where there's very little change over time in terms of the actual slope than it does with disease-modifying therapies where there's a change in slope. On the right, we see the delay, the time saved, and again, we see that gets larger over time. So we see the dynamic process of an increasing drug placebo difference over time. That might be for a biomarker or it might be for a clinical measure. Next slide. So here's what we're seeing in the clinical trials of the monoclonals. So if you take a composite like the CDR sum of boxes, there's around 25% slowing. With the IADRS used in a donepezil in the donanemab trials, it was around 30%. Cognition, ADLs and ADLs run between 25 and 40%. So those measures seem to be maybe more responsive. On the NPI, it was used in only one trial, and there was an 87% drug placebo difference. Patient mood, patient QOL, caregiver or care partner burden, and the care partner quality of life all have varied between about 25% and about 50%. So this is the kind of slowing we're seeing. Then we need a discussion about, are these important and meaningful? Next slide. So here's the observation from the lecanemab. You saw this from Dr. Peterson. This is just real world data. So you see that there is a change of slope. You see that there is an increasing drug placebo difference over time. You see that there is increasing benefit with longer exposure, and the truncation at 18 months is arbitrary. That's just how long we think we can go with the trial before we begin to lose patients from attrition. There's an increasing time to event. That's the horizontal measure. There's a correlation with biomarkers. There's a drug placebo difference in change from baseline at the trial end, and a drug placebo difference in change from baseline at the trial end in terms of the biomarker measures as well as the clinical measures. Next slide. You can see that there have been also some works at simulations trying to understand what will happen over time with these changes that are observed in the first 18 months. You see that the mean time to mild dementia, if treatment is started in MCI, is about 2.5 years. The mean time to moderate dementia would be about 2.13 year delay, and the mean time to severe dementia would be about 2.34 year delay. This is a 0.75 quality improvement and about a 6% decrease in probability of institutionalization. Again, these measures can be generated, and the question is, how do we think about this from an importance and from a meaningfulness point of view? Next slide. So I just wanted to tie this to some of the discussions that we've been having in a broader way from Dr. Riley's discussion yesterday. What matters most to patients? Of course, they would love to have improvement of memory. We do not expect to achieve that with disease-modifying therapy, but we do expect to slow progression, which was highly ranked by 1/3 of the patients. Remembering their family, 20%, remaining independent, 10%. Those are things that can be achieved and would be captured in the time-saved analyses. So what matters most to patients are not usually included in clinical trial assessments. This is a gap we have to fill. The answers tend to be not quantitative. Patients value improvement. Goals are largely aligned with those of current DMT development. Although we see that greater efficacy is needed. Now, I want to make a point about the patient's Bill of Rights, because this has come forward from the voice of the patient organization. I think it's very important, and what they have said is that we have the right to approve, to try an approved FDA therapy. And it's very interesting to me that they do not specify a magnitude of benefit. They do not specify 30%. They do not specify an MCID. They say, if it's approved, if it has been found to be efficacious and safe, then I have the right to try that medication. I think it's a very interesting perspective and one with which I am aligned. Next slide. So finally, I'll just say that we're trying to create a pathway, a policy pathway from discovery to integration in care. And this will have to take into account the magnitude of the effect and the duration of the response and the scope of the effects. We'll have to think about safety and tolerability and convenience. We'll have to talk about cost and budget. And of course, we have to entertain the perspectives of many stakeholders. I'm confident we're going to be able to achieve this, and the conference is very helpful in helping us towards that goal. Thank you.
All right. Are we taking a moment for questions?
We can do them all
first?
at the end.
We're going to save them all
You
for
had
the
a
end.
question
Okay.
that you wanted to ask right now. Either way.
Okay. I think let's go ahead and move on to the next speaker and save questions for the end. I think that would be easiest with the chat. So we're going to move on to Julie Zisimopoulos, who we have her slides up. Okay. So Julie Zisimopoulos is going to is a professor at the University of Southern California in the School of Public Policy, and is a senior fellow at the Schaefer Center for Health Policy and Economics. And she's going to give us a presentation on the health economics perspective on meaningful benefit. So Julia, off to you.
Thank you. I want to start by thanking our colleagues at NIA and NINDS for organizing the workshop and really for inviting Health Economics to be a part of it. And my gratitude to Teresa and Joe for organizing and moderating the session. And to all the colleagues that have already gone and spoken before us for their excellent presentations and insights, and for my colleagues on the panel. My research is supported through grants from the National Institute on Aging, and I list them here. And I have no other disclosures to report. Next slide, please. So I provide here 5 topics that are going to outline my presentation, but really there are 3 main points that I would like to add to this conversation, and I'm going to start with them now, and I'll also end with them. So the first point is that treatments will have both health and financial impacts on patients, families, payers, and society, and impacts that they care about. Second point is that meaningful benefit in the short term does not sufficiently account for the quantity and type of long-term benefit. And we can use models to help provide some insight and quantify these long-term benefits. And I'm going to use the example of lecanemab to illustrate this point. And then the third point is that how we measure meaningful benefit will have societal spillovers on future innovation of treatments. Next slide, please. So individuals and their families face a trade-off between functional, cognitive, behavioral health, and financial health. So not just their financial resources today, but their future financial security. So a question to consider is whether the treatment or intervention produces sufficient reduction in costs or increase in benefits to be considered meaningful or beneficial. Next slide, please. So it's important to measure these benefits and costs to allow all stakeholders to assess the meaningful benefit from their own perspective. So whether clinically meaningful implies meaningful benefit will depend on a number of costs and benefits, and they may accrue at different points in time, may accrue over different lengths of time, and to different affected persons. Here I just speak about patients, their care partners and families, and institutions such as payers. So this table shows a list of multiple factors that may be impacted by a treatment or intervention and who they would likely impact. If we can quantify them, then stakeholders have more information for assessing these meaningful benefits. So for example, does the treatment allow a person living with the disease or their care partner to participate in the labor force and continue to be productive? Does it impact their enjoyment of leisure or social activities? And this was a theme or idea that was expressed yesterday, this idea of assessing positive outcomes. What is the treatment's impact on future needs for long-term services and support? And does the treatment provide hope for the future? So not just for persons living with the disease, but also for those who are not currently living with disease, but are at risk of disease as they age. And how do the different groups value this treatment? The treatment will likely impact medical care costs today and future medical care costs. For most, there will be cost sharing of covered treatments, and the treatment may also impact medical spending on other comorbid conditions. There may be pain and fatigue associated with the disease or treatment administration and side effects, and these may be quantified. And side effects may cause discontinuation of a treatment or intervention, reducing the potential benefits. And potentially side effects may increase the risk of death. So another point that I would like to make about these costs and benefits is that there are different ways to measure the value of these factors for which there is no market or no price, such as the value of social engagement or hope. One method of evaluation is based on a collection of stated preference data to elicit an individual's willingness to pay to obtain a specific good or willingness to accept to give up a good. Next slide, please. So I just briefly want to provide an example that's an illustration of a disease-modifying therapy that delays cognitive and functional decline at early stage to illustrate these trade-offs. So suppose we have a disease-modifying therapy that supports supports the workforce participation and productivity of the patient and the caregiver. It increases leisure or social enjoyment, quality time with family and friends, reduces the lifetime need for long-term services and support, and also provides hope for a better life or reduced fear of financial destitution. On the other side, it may also impose high out-of-pocket medical care costs. It may also impose high costs on the payer, and this is not only paid for by the current generation, but also the future generation, the children of the current generation. It may entail suffering via treatment administration or side effects and shorten the lifespan. Next slide, please. So using dynamic microsimulation models that include health, economic factors, and demographics, we can quantify a larger and more robust set of costs and benefits in the long term, utilizing or starting with these measures of clinically meaningful change. So I will use the example of Lekembe, and Doctors Cumming and Peterson have expertly described the trial endpoints and results. So starting with those, and then using a large representative sample of middle-aged and older persons who are followed over time, so that is longitudinal data sources, we can use the information on the eligibility for treatment to draw a sample from the data with a distribution of characteristics that look like the trial participants. Employ those clinical endpoints and model and estimate how functional and cognitive change of the treatment translates into these other measures that we care about, such as the reduced time of care services provided by caregivers or care partners, the impact on lifetime medical care costs, the quality of life of the treated person or their care partner and family members, and the other factors that were listed earlier in the table. That is the long-term benefits for different persons. And next slide, please. So then in order to quantify the value of the treatment, we can compare different treatments against a scenario of no treatment. So in the example that I'm giving here, we compared the value based on the cognitive results reported from the Clarity AD trial. So 18 months with a 27% reduction in CDR Sum of Boxes. And we then compare that to a scenario in which the value of the treatment was extended to 48 months and holding the rate of efficacy constant, but just over a longer period of time. And then to a third scenario where we again have an extended month of 48 months of treatment, but now with a higher efficacy of 50% slowing of cognitive decline. Next slide, please. So in this table, we report results for the lifetime value based on just 3 measures of those that are described earlier. QALYs, informal care savings, and medical care savings for the 3 different treatment scenarios compared to the status quo of no treatment. So you can see in the first column, there is a modest increase in the lifetime value of about $54,000 under the first scenario that's meant to mimic the Clarity AD trial results. This value increases significantly when we increase treatment time that extends the efficacy benefits over 48 months. And that's the middle column of about $144,000 increased in lifetime benefits relative to no treatment. And then you can see there's quite a bit increase in the value to an individual when we extend the treatment time again to 48 months, but we increase the efficacy to 50% reduction in cognitive decline relative to no treatment. Next slide, please. And then the final point for our consideration is that how we will measure meaningful benefit will impact innovation via what research and development of private companies and public institutions choose to invest in. That is, if regulators and payers prioritize particular clinical endpoints, then future innovations will align with those to increase their likelihood of approval and payer reimbursement. Next slide, please. And then finally, I just want to return to the 3 points I began with. Treatments will have health and financial impacts that patients, family, payers, and society care about. Meaningful benefit in the short term does not sufficiently account for the quantity and type of long-term benefit. And how we measure these benefits will have societal spillovers on future innovation of treatments. So I noted here a gap that was, and an opportunity that was highlighted earlier. But I just want to make one final point on the gap and opportunity, which is that the population measure of value of treatment requires rigorous clinical data from persons that represent the diversity of the population. And this was a very important theme and a great discussion from the earlier session today. Thank you.
Thanks very much. And now we're going to go over to Dr. Jose Figueroa. He is a professor of health policy and management at the Harvard T.H. Chan School of Public Health. He's going to be talking about healthcare coverage, payers, and policy implications for the care of people with dementia.
Good afternoon, everyone, or good morning, depending on where you are in the country. Thank you for the invitation to speak today. I want to talk about three things today, and it's more to present an overview about what many believe is going to be one of the biggest challenges that our country will face over the next 5 to 10 years. And that's how do we afford and cover emerging technologies, emerging therapeutics for our aging population. And to get there, I want to first talk about how are people covered when they have dementia in terms of healthcare insurance, and then talk a little bit about who pays for care for the people with dementia currently today. And then importantly, as I talked about, what are some of the most important payer and policy challenges relevant for the people of dementia. And as a reminder, many of these numbers have already been covered throughout the day today and yesterday. As a reminder, more than 6 million people currently living in our country with dementia. 94% of them are over the age of or 65 years and older. And just by age alone, that shouldn't surprise anyone that Medicare is the predominant payer for the care of people with dementia. 95% of those with the diagnosis of dementia are enrolled in the Medicare program. The majority of them qualify because of age, and a small minority, about 5%, qualify for the Medicare program for other reasons, including disability, end-stage renal disease, and other conditions. And the other important fact to know that about 1 in 4 people who have dementia that are enrolled in the Medicare program also are dually enrolled in the Medicaid program, often called the dual eligibles, dual eligible for Medicare and Medicaid. And so a key point is that people with dementia are predominantly insured through public insurance programs. And I put public in quotes because I'll talk about in a minute. There's increasing private managed care happening in our country for caring for those with dementia. So it is a taxpayer problem predominantly, and not necessarily the responsibility of employers or employer-sponsored insurance to meet the needs of those with dementia. The other thing we all know is that we are the most expensive country in the world when it comes to our healthcare system. About $4.5 trillion in the US are spent in caring for our populations. This is almost twice as much as the nearest high-income country, our neighbor, in terms of what we spend, both in absolute and relative dollars. Now, there's also many problems in the United States of why we're spending so much money. One of those is we know that there is rampant failure of care delivery. Even when the evidence suggests we should be doing certain things, on average, many people in our country do not get evidence-based treatment related to treatments for diabetes, treatment for hypertension, and other conditions. Failure of care coordination is a massive problem in our country. There is rampant overtreatment and low-value care as well. There's unfortunately a lot of fraud and abuse, especially in the Medicare and the Medicaid program, because there's often not a lot of oversight for ensuring over 140 million people. There's also administrative complexity, which I'll talk about in a minute, is also a major problem. We have 1,000 insurance plans, different kind of networks within them, plan benefit designs, very complex insurance system in the United States. Now, what we also know that if you're a person with dementia, care delivery is unfortunately worse. Care coordination is worse for people with dementia. Overtreatment and low-value care, unfortunately, also worse. Fraud and abuse, people with cognitive impairment are more likely to be susceptible to scams. And then the administrative complexity given as well is really hard to navigate for people with dementia and their family members and caregivers. So that means when you put it all together, healthcare use is higher, healthcare spending is more for caring for people with dementia. Clinical outcomes are not necessarily better, they're often much worse. Quality of life for people with dementia is worse than those without. And unfortunately, patient experience as well is often not as great as those without dementia. If you look at estimates out there, about $350 billion a year is estimated to care for this aging population with rising complex multimorbidity, to keep them as healthy as possible and as home as possible. But unfortunately, many of them end up institutionalized, as you all know. And if you look at, in terms of the question, who is paying for this, the majority of it falls on public programs like the Medicare program, where about 45% of total dollars for the formal care of people with dementia is paid out by the Medicare program. 19%, or about $65 billion, are paid by the Medicaid program. The majority of this is in long-term care and also behavioral health care. And then 25%, major issue, is out of pocket. About $1 in $4 for the formal care of people with dementia is paid by patients and family members, and 11% through other supplemental insurance programs, sometimes through the employer that has very generous packages, but only a minority is paid through that. So another key point, beyond, there's 2/3 paid by taxpayers and $250 paid by patients and family members. Now, what are some of the key payer and policy challenges facing our country today? I'm going to just describe 3 of them. And this is not, there's more than these, but these are 3 that I think are very important. The first one is that we have a rapidly increased enrollment of people with dementia in Medicare Advantage, or Part C. That's the private managed care option. It is an alternative to traditional fee-for-service Medicare. That's number one. The second one is among those who are dual eligibles, which are the low-income, socially vulnerable people, predominantly Black, Hispanic, people of color, there is a lack of integrated care, and I'll talk a little bit about that in a second. And then the third one is coverage and affordability of emergency therapeutics. The first problem, Medicare Advantage, rapid growth over the last decade and a half. We went from 19% of the Medicare population being in Medicare Advantage in 2007 to over half in 2023. And it is even higher today in 2024. But in 2023, 51% of the Medicare beneficiary population is in Medicare Advantage. If you look at specifically those with dementia, it is a little lower by a few percentage points among those with dementia, but the rate is increasing in a very similar in a very similar way among the between people with dementia versus those without. So what does it mean to be enrolled in Medicare Advantage? Now, this is a very hot topic currently in Congress today. There are many proposals to think about how to regulate Medicare Advantage plans, and there's a lot of controversy in terms of the value of Medicare Advantage. And, there's a lot of evidence out there that says Medicare Advantage does maybe really well with certain things, but then there's a lot of evidence that suggests maybe that we're overpaying for Medicare Advantage. And so I'm going to leave it at that, and I won't go too much into detail about that, but I'm happy to have a separate conversation later. But the first thing to know is for people who are enrolled in Medicare Advantage, they do face some unique obstacles. Number one, there are restrictive physician networks to be in a managed care plan, and some MA plans have more restrictive networks than other MA plans. The second thing, it is many of them have very complicated benefit designs. Many of them require prior authorizations to use services. Now that is a challenge when someone has cognitive impairment, to figure out all of the rules and regulations of how to navigate the prior authorization, which suggests that maybe there's some evidence that access might be an issue for people with dementia as they increasingly enroll into Medicare Advantage, or at least maybe delays in getting services that their physicians and providers think they should be getting because of the wait time to get prior authorizations. The other thing is that there are many MA plans within us. When people are going out and choosing an MA plan, there's so much choice. There's choice complexity, choice overload, and there's some evidence to suggest that those with cognitive impairment unfortunately have a much harder issue trying to figure out which is a good plan that meets their specific needs than others without cognitive impairment. Now, the other thing that's really important is some recent data that shows that those people with dementia that enroll in Medicare Advantage are more likely to disenroll from Medicare Advantage rather than those that do not have dementia. And that's maybe some of the reasons are for the points 1, 2, and 3 above, that it is harder for them to maybe get the care that they need. And then the last thing to note is that the racial and ethnic minorities with dementia, there's concerns that they're more likely to enroll in lower quality MA plans than those that are higher quality. Some of it has to do, because of reasons, is that that's the only plans that they are available to enroll in, depending on the area that they live in. Problem number 2, lack of integrated care among the dual eligible population with dementia. As I mentioned, about 1 in 4 are dual eligible to qualify for both the Medicare and the Medicaid program. These are people who are living in poverty. These are people with a lot of issues around the social determinants of health. And one important fact is that the majority of these dual eligibles have to navigate a bifurcated coverage system. That means that they have to navigate the Medicare benefits and the Medicaid benefits separately. If you ask the question, how many of them are in non-integrated care models, meaning separated coverage models, 2 separate plans, versus an integrated model where it's one plan managing both their Medicare and their Medicaid benefits, in 2013, only about 2% of the dual eligible population were in what we call integrated care models. And it increased slightly to 9.4% in 2020. If you look at 2023, it's closer to 11%. So the majority of those who are dual eligible are not enrolled in integrated plans. Why does it matter? There are reasons why we think financially integrated care is very, very important with dual eligibles. What it means is that it's 2 separate budgets, 2 separate insurance programs, and it is up to patients and family members to figure out how to navigate both of them. Who's going to pay for my durable medical equipment? Who's going to help me pay for services at home? Who's going to pay for the hospitalization? Is it, it's predominantly Medicare that pays for the hospitalizations, but if it's long-term care services and support, it's predominantly Medicaid that pays for it. So it is very, very complicated healthcare system to navigate. Again, those and this is unfortunately the people who have cognitive impairment are the least. They're the people that you don't want to complicate the way that or worsen their ability to navigate a already complex care system. The other thing that's really important is that there is little incentive to coordinate services between the Medicare and the Medicaid program in non-integrated models of care. And there's also concern that there is cost shifting. So what that means is, let's say there is a service or a therapy that is highly beneficial, that it could save some dollars, but if the dollars are saved to the wrong program, there's maybe less of an incentive for Medicare Advantage to pay for something that is really costly to the Medicare Advantage plan if the savings are all to the Medicaid program, since they're not going to benefit from any of the savings. So, for example, in the case of lecanemab, as I mentioned, there's evidence to suggest that maybe there's a 6% reduction in LTSS services and institutional care. That's a good thing. People would rather be at home with their family members and not institutionalized. But if it's an MA plan that's bifurcated, not integrated with the Medicaid program, then they don't see any of the benefit. But they incur the full cost of the drug, but do not experience any of the benefit. Now, you can argue because maybe there's fewer hospitalizations, there's fewer post-acute care from those hospitalizations, as Julie was talking earlier, but it is something that payers think about a lot. Who ends up saving the dollars for a service they're paying for? And so we think that this bifurcated coverage system is inefficient, it's confusing, and it's unsafe for many people who are dually eligible. And so integrated care models, just what are they? It is when one organization manages the Medicare and the Medicaid dollars, they're responsible for total costs. So now if you do pay for something through the Part B program, for example, for one of these monoclonal antibodies, and the savings are in the Medicaid side, it is one organization that is reaping the benefit of that investment. And so you would think that they would care more. There is some evidence to suggest that they improve quality, that they improve some outcomes, and that maybe there's potential for them to improve equity. I will say, though, the evidence is pretty weak because we don't have many randomized controlled trials assessing some of these programs. The three big programs that many of you have heard, PACE program is one of them. Medicare Advantage, fully integrated dual eligible special needs plans is another version of these integrated models. And there's some across 13 states, there's experimentation with something called state Medicare Medicaid plans. Those are ending, and the thought is that number 3 will turn hopefully into number 2 in 2025. But don't worry about the details in terms of these plans, but the one thing is to think about it is one budget and one organization managing total cost of care for patients. Now, the last point is coverage and affordability of new therapeutics. We've talked about healthcare costs in our country are rising rapidly. We have an aging population with complex multimorbidity, including rising prevalence of dementia. There's also multiple competing priorities in the country. We've had, for example, in recent years, the SLGP1 agonists, the weight loss drugs, really tremendous results, but they're very, very expensive. $12,000 a year for the treatment, for example, for some of the SLGP1 inhibitors to treat people with diabetes and obesity. Cancer therapeutics, also a major problem in our country in thinking about how to afford them. Gene therapy, other new technologies coming on. The Medicare program and the Medicaid program have to figure out how to deal with emerging technologies that have very promising results in the care for patients, including people with dementia. And so just to give a case study in terms of the lecanemab, this is just the short-term cost. Now, Julie talked about some of the important things about thinking about long-term costs, but if you just look at the short-term cost, this is what Medicare currently is facing. List price is about $26,500 per person. This does not include the weekly, the biweekly, bi-monthly infusions, all of the CAT scans, imaging that people need, all of the visits, the follow-ups. If you add up, it's estimated that it costs about $82,500 per person. A lot of it is out of pocket because with Part B, even if it's Medicare Advantage, depending on the plan, you might pay a little less. But in traditional Medicare and Medicare Advantage, there's a 20% coinsurance rate that patients and family members are responsible. So over $5,000 for that. Equity concerns a major issue because if it's the more you have to pay out of pocket, lower income people, Black and Latino people are less likely to be able to afford it. There is a substantial concern among MA payers and CMS in general about how to afford some of these drugs. And just as an example with aducanumab, when that came into the market briefly, it led to a 15% increase in Part B premiums that people had to pay out of pocket in 2021 to 2022, mostly in anticipation that it might have been used a lot. Obviously, it's no longer in the market, but it did raise premiums. Just one drug raised premiums by 15% across the entire country, not just people with dementia. So just some estimates. If we look at how many people will use lecanemab over, in 1 year, if we had 100,000 people in our country using it, it would mean $2.7 billion just for the cost of the drug. If it goes up to 5%, about $9 billion. And if there is 10% of users, meaning 10% of people with dementia that meet the criteria, closer to 18 billion, so about 670,000 users. As a comparison, all of Part B to pay for all drugs related to cancer and other treatments, $40 billion a year are spent in our country. And so this drug has the potential to be a huge chunk of what Medicare pays through the Part B program. So it is something, and this is just the short-term cost. So this is definitely on the minds of a lot of Medicare Advantage companies. How can we afford these new drugs? The other thing that's been discussed is this prescription digital therapeutics. There's a lot of effort in terms of bringing this to improve the care of people with dementia. The one thing to note is the answer is quite easy in terms from a Medicare perspective, in the sense that it does not currently cover the majority of prescription digital therapeutics, even if they're FDA approved. Medicare does pay for software that is embedded in durable medical equipment, but it does not pay for software use, for example, that you would download on an iPhone or an iPad. It is not something that is covered through the program. So if anybody wants to, usually falls into the pockets of patients and their family members. CMS has tasked MedPAC, the advisory committee, to help review coverage for prescription digital therapeutics for advice. Should we be covering it? If so, how should we be thinking about it? There was a recent report on this that the answer right now is that they're very, very concerned about it. They think that paying for prescription digital therapeutics may undermine the integrity of coordination and payment bundles. So Medicare is moving towards value-based payment, and providers taking increasing risk. And we shouldn't go back to paying for individual sort of software. This should be maybe, providers should be investing in things that they think are good for patients, and it should not be up to Medicare to figure out what to pay for. If providers see value in a prescription digital therapeutic, they should maybe provide it. An example, for example, there are quality improvement interventions out there that lead to reductions in hospitalization use, but that quality improvement intervention is not something you bill Medicare for. It is a process that providers, and sometimes they use technology as part of that quality improvement intervention. And so it is up to providers to figure that out. So this is something that I think is going to get more and more attention. There are discussions underway and more hearings about this later. So I will stop there. Thank you for your time.
I want to say thank you to all of our speakers. These have been great presentations. We will open it up to questions from the chat. Before we get to those questions in the chat, I'm going to ask one question that it would be good if each of our panelists could touch on, which is what is missing from our current repertoire of tools that could provide additional important information regarding meaningfulness in trials and in health economics and outcome studies. I'm not sure who would like to take that first, perhaps Jeff?
Yes, happy to plunge in.
Yeah.
Thank you. I mentioned that I think our current absence or lack of patient-reported outcomes, even for patients in prevention trials who are perfectly capable of having a very informed and insightful opinion, are lacking. And for patients deeper in the disease where insight can be modified, we don't have good care partner or observer RO tools that are often used. So I guess I have a question for you, Teresa, which is, if we have such tools, would they be seen as primary outcomes because you've expressed this great interest in the patient's perspective, or would they be secondary outcomes? How would you see ranking them in the priority of trial outcomes?
Well, I think there is potential for either patient or clinician or observer reported outcomes rather as primary endpoints, but it would ultimately depend on the type of tool that's developed, and the type of questions and what exactly they're assessing. I would say in a broad sense, we are open to those things. One of the challenges which you just touched on that we have with patients who are even very early in the stages of Alzheimer's disease is, initially we may see patients have subjective cognitive impairment before there's something that's more measurable. And I do think the idea of having a patient-reported outcome in those stages of disease is interesting. One of the concerns that we have is is as the patients progress, then they may lose insight into their impairment, and that's when observer-reported outcomes would become more important. The challenge is determining when you can switch from a PRO to to an observer-reported outcome. I tend to think you might need to do both in a clinical trial, at least initially, even in early stage patients, so that to look at that and see if you start to see a divergence in what is being reported. But I certainly do think that there's potential there for us to consider, these sorts of tools in, for a primary and certainly as a secondary endpoint in our trials. Thank you. Julie, did you have anything that you would like to comment on in that regard about tools that may be missing?
Yes, thank you. Thank you, Tracy. I'll just emphasize a point and expand upon it, which is that identifying and valuing the factors that patients and families care about that are not bought and sold in the marketplace. So we have tools, methods to do this, but we don't have data from a lot of populations. So if we want to employ willingness to pay or hedonic pricing types of methods to understand how people value different aspects of a treatment, or we don't have the data, particularly from non-white populations. So there's a gap and an opportunity, and we need to go out and collect that data.
Thank you. And Jose, I know you didn't specifically address tools or assessments, but was there any existing gap that you would want to comment on?
No, I do want to comment. I see there's Sue Peshen is in terms of a clarification in terms of the 15% premium. It is true that it was increased by CMS without actually looking at the full cost. It was just an anticipatory increase between 21 and 2022. But I just wanted to clarify, but nothing else to add.
But they increased it again, just to respond, they just increased it again and blamed the drug again, or the drug class in the background materials. It's being sort of politicized, and given that only about 2,000 folks, are on drug, CMS has to stop doing this.
So I'm going to jump in here. Thank you for all of your comments. This is Joe Hutter from CMS, and I wanted to make one comment, and then I'm going to pass to Julie, and then I'm going to come back with a question for Jeff. Julie, I think you're going to respond to, I think, Ian, you have your hand up. Thank you for patiently waiting. Julie's going to respond to that question. She offered to do that in the chat. First, so actually, why don't we go to Julie? Go ahead, and you can answer those Ian's question, I believe you mentioned, and then I will return to a question to Jeff from me.
Sure, but Ian, would you like to restate your question in case not everyone's following the chat?
Sure, I'll at least give it a shot. And Julie, good to see you. Thank you for your presentation. Just trying to wrap my head around how projections about potential cost savings to the healthcare system related to a disease-modifying therapy or other therapies might be calculated. And in chat, I gave a couple examples: falls risk being reduced potentially for somebody who has a disease-modifying or slowing therapy, and maybe more particularly diabetes. I know there's been a lot of work done about how the combination of the presence of dementia for somebody with diabetes really radically accelerates the cost to Medicare and Medicaid of diabetes alone. And so what I'm wondering is, how do you interpret those costs beyond the long-term care costs? So I promise I'll stop after this, but it's the hospitalizations as well as the long-term care cost, but then it's even extrapolating further out, things like the value of someone maintaining their sight by virtue of not losing it to diabetes, maintaining their limbs by virtue of not losing them to mismanaged or undermanaged diabetes due to the dementia overlay of the diabetes complicating its management. So sorry, that was a little bit of a winding thing, maybe a little more clear in chat than what I just said.
No, thank you. And I think you provided some of the answer. which is that there are costs that are potentially saved because persons with dementia tend to have these other co-occurring conditions. And so you alluded to some of those potential cost savings to families, patients, payers. I'm just going to, I think, add one thing to that, which is that the treatments, whether they are disease modifying or looking to repurpose medications, statins, antihypertensives, metformin, they have the potential to act on these shared pathways of, say, cardiovascular disease and dementia, or diabetes and dementia. So there's these additional potential savings through these treatments by acting simultaneously on the diseases if we have a better understanding of those shared pathways.
I apologize, just quick follow-up. Do the models that you're referencing already take into account those kind of secondary and tertiary costs, or just the straight up dementia long-term care institutional costs?
Okay, sorry, I missed that part of it. Yes.
My fault.
I think that the key to these models is that we are we're estimating and quantifying these competing risks. So taking into account those other health conditions that persons have along with the dementia and with the risk of death in all of this too. So yes, sorry, Ian, I think I misinterpreted your question.
Yeah. So I'm going to jump back in here. Ian Kramer and I and Ian's brother actually all share an interest in prevention. And, here's just another example. If whether it's clean water in developing countries, or in another case, if you adhere to hypertension medications, perfectly, half of heart failure would disappear. Lots of stroke would disappear. So that's in the background of everything. And do those things matter for patients with Alzheimer's? Yes, they do, Ian. And we both agree on that. I am going to pivot to a question to Jeff. You mentioned that patients have a right to try a drug if it's FDA approved. Jeff, can and should we all collect data while we are treating these patients so it's not either or?
Yes, absolutely. Information is key to understanding the transition from the clinical trial to real-world evidence. And we have to have real-world evidence. After all, if these drugs only work in trials, then I don't think we have achieved our goals of helping the public health. So yes, we need the registries. So there's a CMS registry, there's ALZNet, the Alzheimer's Association registry. There's one from Emory, I think, that is collecting data as well. And we really encourage our doctors that are working with and the patients, although the patients usually don't enter things on the registries themselves at this point. It's usually through the doc. And they have to be manageable. The CMS registry is very manageable, and we have to get enough information to guide the future, and some of the other registries are more robust in terms of the information that they get. So I think we're also learning about registries at this moment, but we absolutely need the real world data.
Yeah, and just as a footnote for other registries in other fields outside of Alzheimer's, these have always evolved. There's a 1.0, everybody outside, it's a public-private partnership, right? It's industry, it's academic, it's government, it's whoever has a new mousetrap or better idea. Here's how we could do this better. And, if you have a combination, some are very, very simple, very low bar to getting in, but you're meeting patients and doctors where they are so you can contribute to the degree you can. And, for the arguments that, sometimes these are too simple, like ours, there are more complex ones. There's a future very large infrastructure, which I know NIH is going to be supporting, but that maybe jumps ahead of where we are today. Luke, I don't know if there's where we are in the time. This is extremely helpful to all of us in government to hear your candid thoughts, even when we disagree. I think there's more that unites us than divides us at this point. I think we're all trying to figure out that key question. How do you treat everyone you can who's indicated while collecting that data efficiently? And that'll help not just future research, future patients, which is the goal of research, traditional research, but also the current ones. If you're starting on a drug tomorrow, 6 months from now, depending on what that drug is, or if you're starting on one, say 3 months from now, you're going to want to know certain things like, gee, how does my risk benefit change over time? Do I stop taking the drug at some point? If so, what's the evidence for that? And what if I'm in one of these subgroups? Is there more data that will help me make a decision as I go forward? So with that, I'm going to pass it back to Luke. Luke, I don't know if there's any other burning questions in there, or
yeah, there are two more questions in chat. We have a little bit more time for this session. Andrea, do you want to come on and ask, or I can read your question for you? So maybe I'll read it. And if there's follow-up, Andrea, oh, you're here. Do you want to read it, Andrea?
Yeah, sorry, I'm just having a hard time finding my unmute button here. Yeah, I'm just curious about, and I know that none of this is final yet, but CMS kind of requested feedback on policy changes for how researchers would access data, and that they would all be accessed by the VRDC environment. And currently, researchers might link Medicare data within other cohort studies or with other data about sort of like social exposome factors that I think it sounds like we all have this issue with representation, and this is one of the great strengths and maybe one of our great obligations with opportunities for Medicare data is to represent, really a very large sample of diverse individuals. So I guess I'm curious what folks think about like the data needs, and is there an opportunity to think about, like, I don't know if we're going to be able to continue doing that. Will we be able to evaluate these financial outcomes and other like utilization outcomes that correlate with financial outcomes if we're no longer able to link Medicare data within our cognitive aging cohort studies? And what does that look like, and what is the need with that regard? I don't know if people have thoughts on that.
I'm happy to briefly say that I think the academic research community was up in arms when it was announced. It came out of nowhere. People are very surprised. As someone who has invested a lot of time, energy, sweat, tears into building physical data infrastructure at our institution, for it to go away completely starting next year and move completely to a virtual environment, we think is going to be a major challenge. Mostly because to do kind of collaborative research where there's multiple people accessing the data, it is very, very expensive to move to the VRDC. It's difficult to support trainees and sort of the next generation of researchers. But on the other hand, I think it is, we were talking to some folk about it. The concern is security. There's been a lot of security lapses. There's thousands and thousands of DUAs. There's ton of people, who knows how many people have access to Medicare data. It is possible with Medicare data to identify individuals, including US senators, if you know their age, and if you know if they were hospitalized, and if you know where they were hospitalized. If a hacker gets access to that data, you can identify people, you have access, you can link it back depending on where that. So security concerns are very, very real. And I think this is going to be an evolving challenge. I think it's going to lead to, for your example, a lot of people link Medicare data with registries, and how is CMS going to facilitate that process now moving forward? Is it going to allow some use of physical data to allow that kind of activity, or is it not? And so those are all questions that are yet unanswered. But the concern is that in the immediate short term, that it will slow down research, and it is going to price out many people, especially those with limited resources. Ed.
Thank you. Suzanne Hendricks, do you have a question, I believe?
Yes, so my question was whether any of the pharmacoeconomic models we looked at today from Julie and Jose, if they factor in the differential impact of a disease-modifying therapy compared to symptomatic therapy. And essentially, treating it as symptomatic means you just count the effect right when the treatment is being given, and it's just the benefit you're seeing on the scores. But there's quite a bit of evidence with these disease-modifying therapies that at the end of the treatment period, you are a natural patient. You'll progress from that point onward. And so the time savings that you had during the study would continue with you for some amount of time.
Is any of that factored in, or is this really just including the time on treatment?
Suzanne, I can speak to that. Thank you for the question. I can speak to that in our current model. So that particular point of extension of treatment effects is part of the description that I provided when we had the extended treatment effects. So that was underlying assumption of linear slope that both Dr. Cummings and Peterson showed. But I think part of the value of the models is that those types of assumptions can be changed as we get more information coming out of the real world evidence about how those effects either decline over time, stay constant, and for how long. And then the models can incorporate that information. Does that
Yeah, and when you showed, I believe it was like a 48-month time period, I assumed that meant that the slopes were continuing to separate and not then parallel and just maintaining that benefit. So I think what you're saying is that a disease modifying effect would be partway between the 18-month effect and the 48-month effect, because you wouldn't get the additional accumulation up to 48 months, but you would maintain more of that 18-month going forward that would be part of what you showed for the 48. So it sounds like it's kind of partway between the two, and that those are flexible aspects of the model.
I think finally, I wanted to call out, actually, there's something that Lupe Morales had mentioned, and I just want to draw attention to that. It's in the chat at 1:57 p.m. She's making the point that I think we all realize, and we can never forget. It's complex to navigate the medical system, the insurance system, and then those are two different parties who are interacting themselves. And she's right. And, you know, I think there's no substitute for having a primary care physician, having a social worker, having a navigator, you know, who's not a physician, help navigate these systems. And there's some, you know, organizations out there at Barbara and, you know, Alzheimer's Association, others who help people navigate this complexity. Hats off to them. And our job is to try to make this all of us, make it increasingly easy to do it right. Thanks. And Luke, turning it over to you.
So thank you. This is a great session, a great 2 sessions. I'd like all the speakers and moderators for this last 2 sessions to please come on camera. Now is the time for a general discussion across both sessions. Speakers from the previous day as well, and moderators, please join in on the conversation, as well as the rest of attendees at the meeting. And so it's open for all of you, and we have until about 2:40.
I'm just gonna, Sue Peshin just asked, actually, it's a rather good question. Sue, are you there? Why don't you just go on camera? If you
Sure.
are, you don't have to. Now I can see you.
No,
How
I'm
are you,
happy
Sue?
to.
Okay.
Yeah.
And so
Hi.
actually she brought up a good question, and is, you know, the relationship between the real world data NIA platform to that's coming, right? And I'm not going to speak to that certainly. And the CMS CED policy. There's a lot of misunderstandings about what CED does and doesn't do, and NCDs and all of this. And in this one, let me try to provide a little clarity, but you tell me, Sue, if I'm, and others, if I'm being clear. In this, the CED policy will support for these FDA drugs that achieve the traditional approval, right? Direct evidence of clinical benefit or improved health outcomes, right? For those, we're supporting anything that could be a standalone CMS approved CED study. And we've had 3 or 4 of those comes in. Also, and the wording is pretty much any NIH research without our further review. So if NIH is pursuing a trial or study in this space that they believe is appropriate, we don't come back and say, oh, let's match that to our criteria and here's our thoughts and maybe you should tweak that outcome. It is in their hands. We're not overseeing them. We're not duplicating their effort. We're supporting the studies that are coming out of NIH without our further review. Now, can there be coherence and interoperability of data homogenation, all of that. All of those are good things. No one would disagree. So yes, that can all happen, but no, NIH isn't sort of falling under our rubric. We're supporting them. They get to determine what they do. Sue, is that a direct answer to what was a direct question?
Yeah, it wasn't really a question. It was sort of more a comment, which is that I hope that it is not used in the context of the CMS CED policy, so that the actual platform is not sort of counted among the other clinical studies and registries that CMS has. I don't think that that there should be a overlap there, because I don't think it's appropriate. And this is a payer tool. CED is a utilization management tool under CMS, very different than a real world evidence.
It's actually not.
Platform. It is, and we've worked on a number of coverage with evidence development determinations. It's also an interpretation by CMS under
I'm not going to get into a
NCD
debate with you,
statute.
Sue, on that. I think it may be to sort of how you're defining a utilization management thing. Most of those things have to do with like cost effectiveness analysis or things like that. And let's look at the volume and try to keep volume down. We don't do that in coverage determinations at all, that aspect. Innovation Center has, but getting back to the core of I guess it wasn't a question, it was a comment. The answer is, and I'm just putting this sort of in layman's terms here. There's obviously legal detail behind here. And my goal here is, I'm speaking on behalf of myself, is just to be helpful. That's what I'm trying to do, is that basically, in layman's terms, CMS is getting out of the way of research NIH would want to do, and that's in the policy itself. Jeff, I know you have your hand up.
Yes, I was thinking about Fanny's data. So Fanny, maybe I'll ask you a question if I could. I was struck by the heterogeneity of the pathology in the minority communities. You showed those circle graphs that showed that white people are more likely to have more A beta and diverse non-white participants less likely. That might mean that our current clinical trials were positive because they were mainly white. How are we going to meet that challenge? How are we going to use the data that you showed to create populations that match sort of the mechanism of action of the drug? It looks to me like we're going to have people who have a predominance of A beta pathology if we're going to use A beta drugs. And therefore, people who have mixed pathologies might need to be recruited into different trials and might need to be treated with different medications or combinations of medications. And I thought your slide invited that line of thinking, and I wondered whether you would share your thoughts.
Yeah, absolutely. So that's from the UC Davis Brain Bank. And I think we lack actually diversity in brain banks in general. We lack in living cohorts, but also brain banks. So looking more at brain tissue is going to be helpful. But yeah, absolutely, Jeff. I think the problem is that in the real world, A beta is going to be a smaller component of neurodegenerative disease and dementia causing disorders than we anticipate. Now, this is, I think, why we need better biomarkers of microvascular disease. I think Lewy body disease, TDP-43 may have something, just so that we can then optimize the effect sizes for drugs that are very specifically targeting one kind of pathology. Alternatively, we may have, as you mentioned, there are a lot of drugs in the pipeline. If there are drugs that are not specific to proteinopathy, they could benefit potentially multiple different kinds of pathology. Now, in living individuals, MRI is what is used for microvascular disease, but it's not very good because white matter hyperintensity is really not specific enough. In ways. So maybe combining risk factors like blood pressure, hypertension, imaging, and then we really just need fluid biomarkers. So I think the work that is currently funded by NIA and NINDS to develop fluid biomarkers of microvascular disease is going to be incredibly important in diverse populations for risk stratification. Thanks for that question, Jeff.
I just want, Suzanne, I'll get to you in a second. Walter Korshitz has joined us and has made a point here that any of the speakers could comment on. He says, as I understand it, the exclusion rate for African Americans in the anti-amyloid trials was significantly higher than in whites. Most of the difference in eligibility due to low A beta, whoop, it just jumped, on PET. Any comments there, insights from our speakers?
I would just say, and Ron probably knows something about this as well, but I was thinking that that's exactly right. If you look at the A beta loads of people coming into the trials identified with the current biomarkers, they're the same, but the number of minority individuals with positive biomarkers is substantially lower.
Yeah.
So that's one of the reasons. That there's also a recruitment reason, but there's also then a screening reason that keeps minorities out of trials. And I think that's one of the things we're trying to understand how to deal with.
And I think, and then I'll go. Oh, go ahead, Ron, please.
I can just add to what Jeff was saying. In addition, cognitive instruments and what we use for thresholds for cognitive instruments for inclusion in trials may be somewhat variable among these different populations. It may not be appropriate for all the populations, in addition to the other biomarkers.
Suzanne, go ahead.
So I was just gonna point out that maybe the research community disconnected a little bit from the real world in some ways in terms of treating specifically individuals with positive amyloid. And that was obviously helpful because it got us the anti-amyloid treatments, which are helpful for that specific population of individuals. But I'm working with several companies that are working on non-amyloid targeted therapies. And it's been interesting because now with the amyloid positivity as a requirement for research, a lot of times it's hard to find a population that regulators in US and Europe will accept that is now this broader population. And what Sid mentioned earlier, which is that the biomarkers differ, how they get there differs, but what you see at the surface in terms of clinical presentation across all the different markers, if you get all of the like functional, global, cognitive, and behavioral outcomes, we're seeing the same kind of picture there. And I wonder if we maybe need to go back and say, all right, let's not only include amyloid positives in our definition of Alzheimer's disease. Let's go back to maybe a broader definition with subpopulations. And then maybe let's tie some of that into not just biomarkers that are mechanism specific and ones that show, like Fanny showed, a really dramatic effect on amyloid and a small effect on clinical, but maybe tie to some that are more closely tied to the clinical outcomes, things like FDG PET or hippocampal volume or whole brain volumetric outcomes, things that historically have correlated better, but some specific mechanisms may interfere with those a little differently. And I feel like opening that pathway back up will be critical to getting approaches that are meaningful. And it's kind of this shift of clinical meaningfulness and outcomes that are consistent across some of these populations versus biomarker outcomes in populations where it's very specific to which type of patient you have.
Suzanne, I really like what you said, and I especially like hearing FDG PET. One of the things that I worry about, Ron raised a really important point in that neurofilament light or atrophy are pretty generalizable. What worries me is that they're later in the stage, and that's why they're also so strongly associated with the decline, how we're measuring it. But FDG PET and hippocampal volume, I think, actually get hit by so many different pathologies, and they would be really interesting to use. The other thing that I also want to put out there is now that we're screening so many people for amyloid because of the therapeutics, it's an opportunity to enroll individuals who screen out of the therapeutics to study and develop our biomarker toolkit to capture other kinds of pathology. It would be a good use of resources.
I don't know if Sid is still on, but I also thought, Suzanne, that Sid set the stage for a a trial where you would have neurodegeneration as the, as the biomarker for recruitment. And you could use neurofilament light and atrophy or FDG, and you would have a much broader community that could come into such a trial.
We've gotten pretty strong pushback in Europe, especially in terms of not being able to enroll a population that isn't amyloid positive. And I feel like, that was kind of a reaction to the stage that we were in and the types of treatments we were trying. But even with mechanisms that aren't targeting amyloid, we're still getting that pushback. And we're saying, well, can we study amyloid, like an amyloid, an Alzheimer's syndrome type population, call it something different. And they say, no, if you want to study Alzheimer's or have the words Alzheimer's on your label at all, you need to require amyloid positivity. And I feel like we really need to rein that back in. And yeah, I'd be super interested in Teresa's thoughts around this too.
And we're going to pivot to Teresa and then Ron Peterson if it's on this point. And then we will switch to a different thing from Priscilla to Jose. So Teresa, the floor is yours.
No, I think this is, raises a very interesting question that we are grappling with. It comes down to sort of what is the population that you're going to be indicated for. And right now we're moving toward, Alzheimer's disease is being defined by amyloid pathology in vivo for the first time, it used to be pathological, but now we have assays, we have, PET, we have CSF, and hopefully soon an approved plasma biomarker assay. So, now that we are defining Alzheimer's disease by amyloid, then if you're going to have an indication for Alzheimer's disease, you're going to need to demonstrate the presence of amyloid. However, there are co-pathologies and there are other contributions to dementia, and we can't ignore those. I absolutely agree that we need to understand whether drugs are effective in the real world population, which has more than just amyloid. But if you're going to do signal, try to identify an effect, you do also want to try to have the most homogeneous population that you can. And so, I do think the idea of enrolling a larger population, maybe doing a primary analysis in the, amyloid positive population that is more likely to be homogeneous and demonstrate an effect, but then certainly still collect data in a larger population is a useful approach and would be very informative overall for the field. That at the end of the day, then we'd still have to figure out if they showed a benefit in everybody, how would we describe that in a label? But that would be a happy problem to have.
Yeah, let's get there.
So on that quick point, then I'm going to pivot to you, Ron, on that point of looking at patients outside of just the amyloid and just Alzheimer's. Walter mentioned that, look, they are starting calls now to look at trials for its anti-amyloid treatments, right? But it's in persons who have amyloid and Lewy body disease, persons who have amyloid and vascular disease, to get at, is there a benefit in these patients who have those comorbidities, since 80% of people with Alzheimer's disease have something else, right? Only 20% of people with Alzheimer's disease have pure Alzheimer's disease, right? So Ron, pivoting to you.
Just a very quick comment on that. I agree with Teresa that I think we need to define these diseases specifically at the pathologic level versus at the syndromic level. So if we define Alzheimer's disease by the presence of amyloid and tau, then people should have those biomarkers positive before we entertain a treatment with them. But we might want to entertain treatments for combination therapy. That's happening early on in the ACTC Alzheimer's tau platform, where we're going to try to combine amyloid and tau therapies. But my question, Teresa, and maybe Jeff, maybe Suzanne, are you seeing an appetite among sponsors for potential combination therapies? And with the regulatory agencies, Teresa, you kind of spoke to this, it's kind of difficult to write the package insert for this, but nevertheless, this might be reality.
Sorry, I would say that I hear interest in combination therapies at meetings, but probably I'm not seeing it trickle its way into clinical trials just yet. I do anticipate we will be seeing more of these in the next few years. And I'm open to suggestions for how we describe these patients and labeling, something I'm thinking hard about. But yeah, I do think this is a growing area of interest, and we will be seeing a lot more of this, and we'll have to grapple with it. Yeah.
And I think initially it'll be more likely to be add-on studies, meaning that someone's already on an anti-treatment and then start something else that you do on top of it, similar to the way we've been adding on to cholinesterase inhibitors for many years. And that after that, maybe someone do combinations. I've seen 2 combination studies out of maybe 30 in the last couple of years.
Also, there's a point that at some, go ahead, Teresa, please.
I was just going to say add-on is the most likely. I mean, add-on is still a combination therapy, even if you're already adding on to an approved product. It's really polypharmacy in that situation, and we see that in many other diseases already. It's more, we've done it with that acetylcholinesterase inhibitors and memantine, but I think other fields like, say diabetes or cardiovascular disease are already very evolved in this idea of having multiple treatments for a same condition. Go on, Joe.
No, it's just like the poster child for, but it was, of course, HIV, and everybody brought that up for over the last 2 to 3 years, where no single drug was doing it. This was a death sentence when you had that. Now it's a chronic disease, and now you have these cocktails. And you all have mentioned at conferences, at some point you want cocktails. It is also possible that one of these cocktails in the future will not just treat Alzheimer's as defined by amyloid and tau and neurodegeneration, but also maybe a similar disease. Does it treat one of these other comorbidities? Maybe it does have a positive impact. Maybe that's going to be synergistic on the end result, which is the cognitive and functional decline, and arresting that. I want to then turn to Priscilla Novak, had a question for Jose, and she's asking him if he could say a bit more about the need for care coordination for people living with dementia in order to get them into innovative treatments. And any thoughts on how to expand primary care capacity to treat older Americans living with dementia?
So happy to add a few comments on that. As we said, navigating the U.S. healthcare system for anyone is extremely challenging, and it's even more challenging among those with cognitive impairment. Coordination is really, really important. And it is a major challenge for older Americans in general to figure out what plan makes sense for them. Once they're in that plan and have insurance coverage, how do they, it's really hard for them to figure out what services they need, what they're even eligible for. And there's very limited coordination between primary care, specialty care providers, and maybe providers in the home, long-term care, for example. And I think there is a movement in our country, both in terms of Medicare Advantage through alternative quality contracts, and also through the traditional Medicare program through accountable care organizations. There is a movement to move away from a fee-for-service architecture into models of care that embrace whole-centered care, patient-centered care, where there's increased accountability, ideally among primary care providers, to be responsible for the coordination of all services for patients, including inpatient and outpatient. There's some evidence to suggest that these care models, there is a benefit in terms of a little bit better quality, better care coordination, and actually some savings. Although there's controversy because some of these, once you include bonuses that go towards providers that do really well, those savings wash out. But that's something that needs to be addressed and will be addressed moving forward. But in order for that to work, I think we need a really strong primary care workforce. And we also need a very strong workforce that is able to care for the aging population, including those with dementia. For example, geriatrics as a field is we have very limited geriatricians in our country, and there's some evidence to suggest that when there's a geriatrician involved, outcomes across the board are better for those with dementia. And the question is, how do we get there? It is a massive issue. Med students don't go into primary care or geriatrics as much in our country because they're not compensated as well. Also, the primary care is a really, really challenging field. It's just like growing in complexity, dealing with more and more complex issues. How do we deal with that, especially if you're not compensated as well as your radiologist friends or dermatologists? It is a really complex field, and so that I unfortunately don't have a lot of great answers for, except the fact that there is a role for the government to play in this. Things like loan repayment programs and other things are in the works. And then the idea is that as we move into more and more integrated care models, that compensation would appropriately go to the people that are playing the most important role. And you could argue that primary care has that role to play, and be interesting to see and track compensation for providers over time.
All right, thank you. I want to go back to Suzanne and then maybe pivot. Luke is interested in hearing from the group about more about digital technologies. But Suzanne, why don't you go ahead with your question?
Yeah, that was actually the comment I was going to comment on, which is that the digital health technologies may be really important in this goal of trying to get later in the cascade and try to get people where they're sort of on more even footing, because it may be that across these different racial and ethnic populations, if you're measuring something that's very consistently measured in their day-to-day life, how they're moving, how they're acting, how they're performing, their verbal communications, their eye contacts, whatever you're able to measure with these digital health technologies, it may help put people on more even footing. And in our experience, you get a lot better sensitivity to progression than you do with individual clinical, cognitive, or global or functional measures. And it may be that these, digital outcomes could give us a more sensitive version of what's really happening in their day-to-day life. And it feels like that would be very meaningful to families and individuals with dementia.
Okay, Fanny, you have a question or a comment, and also then we do want to this is a great discussions, and we don't want to constrain those. We do want to get back to the question of measurement, especially measurement of meaningful change, as Luke points out. But Fanny, please go ahead.
Yeah, this is a question for everyone, and especially maybe Jeff, Teresa, but would love to hear your thoughts. So just thinking about the future, and you guys mentioned chronic disease, other diseases that have been conquered that are not chronic, people are living with it. I can't help but think that we are intervening too late. How we're screening people, how they're becoming eligible for treatment, maybe due to cost and still toxicity of the treatments, it's way too late. So how far off are we from shifting our screening, risk stratification, and willingness to intervene on biomarkers of disease? And they can be specific, but they can be things like neurofilament light, GFAP, the measures that Suzanne mentioned that we know are strongly associated with decline, pending decline. Would love to hear thoughts on that. And what are the obstacles? What do we need to overcome so that we shift to early intervention, preclinical, I would say?
So I can comment on what is happening, and then Teresa can tell us about what should be happening. So there are 4 trials in the prevention space this year, as we looked at across the data from clinicaltrials.gov. 2 of them are in phase 3, lecanemab and donanemab. And so there is some activity in the prevention space, but it's very limited. I love your question because it suggests that we should be looking more at prevention. All of the data that we have suggests that if the disease is less well established, we are more likely to succeed in evicting it from the brain. So I think we want to move in that direction, but so far there hasn't been very much activity there. But Teresa, what would we be looking for outcomes?
Right, so that's links directly to the Alzheimer's disease guidance that I posted in the chat earlier. It specifically focuses on this early stage of patients before you get to overt dementia. It stages what we call 1 through 3, which would be biomarker positive, no symptoms. All of them are biomarker positive, but no symptoms in stage 1. Stage 2 is some subtle signs of subjective cognitive impairment, and stage 3 would be noticeable impairment, but not overt dementia. And that's probably more comparable to what we would call mild cognitive impairment. And we do talk about the need for both biomarkers and clinical outcomes in each of those stages. Even if you're dealing with patients who don't have symptoms, you want to still be able to track if there development of new onset of symptoms during the study. So we want both. We want both biomarkers and COAs, and how we can utilize those will, depend on how the study is designed. It might be a time to onset of a new onset of symptoms, time to onset of transition from one stage to the other, a pre-specified decline that's captured. There are different ways that you can do this with the clinical outcomes, but the guidance is out there so that people can start thinking about it, and we're open to having those discussions for clinical trials. Now, our guidance does align with what are the planned revisions to the Alzheimer's Association now revised diagnostic and staging criteria that have been out in the public domain and have been vetted and are going to be published soon. But what we need is to be able to define what an early stage is using biomarkers in order to be able to have an intervention. I think right now the revised criteria are advocating only testing in biomarkers in patients who have the disease or have symptoms rather, but you need to be able to have that framework in place. You have to be forward looking and have that framework in place where you can identify individuals before symptoms start with biomarkers if you want to prevent the onset of symptoms. And that's really what our guidance and the revised diagnostic and staging criteria are intended to do, is to create that framework. Once we have some successful prevention therapies, and Jeff just mentioned 4 of them, if any of those are successful, and hopefully more than one is, we will have a stage where we can then move from having a framework to actual clinical practice. But we need some effective drugs.
Thank you, Teresa. So I'm going to stop there because we are at time. I left something for us to consider further, which is measurement gaps and opportunities for prevention in midlife. And this also, we're talking a lot about biomarkers. We're talking a lot about pharmacotherapies and disease modifying therapies, but I'd like the group to also consider non-pharmacological interventions as well across the disease spectrums. Maybe for consideration for tomorrow's discussion. So thank you. This has been absolutely fantastic. What a great day. Thanks again to everyone who contributed. This is the end of day 2. So far, it's been action-packed. So I hope we'll close out with the similar energy tomorrow. Tomorrow we'll kick off again at 11. With our lived experience expert panel. And then we will have our breakout sessions. So I encourage everyone to join one of the 4 breakout sessions. I will be floating throughout, but those are, again, the cognitive function, everyday function, biomarkers, and payers, regulators, and health economics sessions. You can join tomorrow. We'll have a break, and then finally we'll get reports from our moderators who will be leading those sessions, have a general discussion, and then we will close. And as a reminder, we will have a workshop report that comes out from this meeting. It's being recorded, and we will post the recordings to the workshop website once we've made them 508 compliant a few weeks after the close of the meeting. So thanks again, and we will see you tomorrow.